So let me read from my script. I call this meeting to order. Good morning and welcome to the Board of Health's Nominating Committee meeting. The purpose of this meeting is to develop a recommended slate of officers for the State Board of Health. This meeting is being conducted in a completely virtual environment and is being recorded. There are several things we would like to review before getting started. With us today are myself, Stacy Swartz, and the chair of this committee, and two members of the board, Drs. Benita Miller and Patricia Kinzer. In addition, there are staff members from the Virginia Department of Health who have physically assembled at the Madison Building in Richmond for this meeting. They include Joe Hilbert, Alex Jansen, Mylon Lai, Whitney Rickman. Lastly, all votes that are taken by the board during today's meeting will be roll call votes. I will be restating the names of the members who make motions or seconds. Attendees, you will not be able to unmute yourselves. When we get to the public comment period, you will be unmuted by the host if you signed up to speak. And do we have anybody signed up to speak during the public comment period?
We do not have anybody signed up, Madam Chair.
Then if there's no one signed up to speak, can we go to take a motion for the proposed the committee members?
Yes.
Okay. I will entertain a motion from one of the two of you.
I have to admit that I just forgot. Hold on. Stacy, can you text me what we talked about?
Oh, yes, of course. Of course I can. Hold on one second.
So that I make sure that my motion is as accurate as it should be. I just want to make sure.
Yes, hold on one second.
My piece of paper is in the other room, I just realized. So I just want to make sure we're good.
Yes, hold on one second. I'm sorry. I get so many text messages from work. I have to get down to you. Hold on a second. There you go. Thank you. Go.
Okay. I would like to make a motion that we nominate Faye Pritchard for chair, Wendy Klein for vice chair, and Jim Schuler and Jim Edmondson in the executive roles.
I have a motion. Do I have a second?
Second.
Okay, the motion is properly second. I have the following nominations: Faye Pritchard, chair; Wendy Klein, vice chair; Jim Edmondson and Jim Schuler, executive committee members. Ms. Jansen, please call the roll.
Thank you. Dr. Kinzer?
Yes.
Thank you. Dr. Miller?
Yes.
Thank you. Dr. Swartz?
Yes.
Excellent. The vote is 3-0.
Okay. By a vote of 3 to, okay, sounds good. By a vote of 3-0, the motion is carried. We have no further business, so the committee is adjourned.
Very nice job, Madam Chair.
Excellent.
Thank you, Madam Chair.
Is it 9:05, Alex? It is by my clock.
Yes, Madam Chair.
All right. Good morning, everyone. I call the meeting of the June 10th, I can't believe it's June 10th, Board of Health meeting to order, and welcome everyone. Our meeting is conducted in a completely virtual environment and is being recorded. There are several things that we'd like to review before we get started. First, the names of all the board members, along with the constituency that they represent, are displayed on the screen. In addition, there are several staff members from the Virginia Department of Health and the Office of the Attorney General who have physically assembled at the Madison Building in Richmond for this meeting. To comply with the governor's orders on social distancing and masks to limit the spread of COVID-19, they will be wearing face covering and sitting 6 feet apart, or whatever is appropriate for where we are today. The list of all staff participating in this meeting is displayed on the screen. Several of these staff members are participating virtually. Lastly, all votes that are taken by the board during today's meeting will be roll call votes, and I will be restating the names of the members who make the motions or seconds. Attendees, you will not be able to unmute yourselves. When we get to the public comment period, you will be unmuted by the host if you have signed up to speak. With that being said, Ms. Jansen, please call the roll.
All right. Thank you, Madam Chair. Mr. Kreitzer?
Here.
Thank you. Mr. Edmondson?
I know he's here. I see him.
I know he's here, yeah. I heard him speak
He's
earlier.
muted.
Jim, you're
All right.
muted.
Ms. Hines?
It's out there. Finally, I was punching the button and it wouldn't let me unmute. Anyway, I'm here. Sorry.
Thank you. Ms. Hines?
I'm here. Thank you.
Thank you. Ms. Harrison?
Here.
Thank you. Dr. Jang?
I'm here. Good morning.
Thank you. Good morning. Dr. Kinzer?
Here.
Thank you. Dr. Klein?
Here.
Thank you. Dr. Miller?
Here. Good morning, everybody.
Thank you. Good morning. Ms. Pritchard?
I'm here.
Thank you. Dr. Puritt? I did not see her. All right. Dr. Schuler? He's muted. Dr. Schuler, you're on mute. You can unmute him. He's unmuted. All right.
Okay.
Dr. Schuler?
Yes, I'm here.
Thank you. Thank you. Dr. Swartz?
Good morning, I'm here.
Thank you. Ms. Waddell?
Here.
Thank you. Ms. Whipple?
Here.
Thank you. Madam Chair, we have 13 members present for the board and there is a quorum.
Thank you very much. All right. At this point, Ms. Jansen will now review today's agenda. Alex, I'm not used to saying it's you who's going to do it, but I'm delighted.
Absolutely. Thank you. Thank you, Madam Chair. So we are going to review the agenda. The first item will be the approval of the March 18th meeting minutes, followed by the commissioner's report with Dr. Oliver. We will then have a short break if need be, followed by the regulatory action update, which I will present. And then we will have a public comment period. As is the case with each board meeting, there is a public comment period on today's agenda. I would like to review how this will work, and we will review this again at the time of the comment period. When registering for this meeting, there was an opportunity to sign up to speak on a topic. The list of persons who signed up to speak was finalized at about 8 this morning. Each person who has signed up to speak will be called in order, along with the name of the next speaker who is on deck. Pursuant to the board's public participation policy, each speaker will have a maximum of 2 minutes in which to speak. There will be a countdown timer on the screen and a bell will ring when the time has elapsed. If the bell rings while a person is speaking, we will allow the speaker to finish that sentence. Then the speaker will be muted and the name of the next speaker will be called. And then we will have another short break. Next slide, please. And then we will have the presentation of fast track amendments regulations of the patient level data system, followed by a presentation from Mr. Hilbert regarding the American Rescue Act plan, and then the development of draft proposals for the 2022 legislative session. We will then have some remarks from Dr. Carey, the Secretary of Health and Human Resources, followed by any other business the board wishes to address, and then adjourn. And Madam Chair, there have been some additional developments regarding the fast track amendments to the regulations that are currently on the agenda for today's meeting regarding the patient level data system. And Mr. Hilbert has some additional information he would like to present to the board.
Mr. Hilbert?
Yes, thank you, Madam Chair and members of the board. Good morning. On Tuesday, a couple days ago, BDH received written comments from the Virginia Hospital and Healthcare Association expressing concern with the fast track amendments that are on the agenda for today. A copy of that meeting, of that letter, was shared with the board, and it's also in your meeting packet for today. Given the nature of the comments that are in the letter, I recommend that the board not consider that regulatory action today, and that the agenda be amended to strike that item from the agenda, with the understanding that BDH will work directly with VHHA and other key stakeholders, including the Department of Behavioral Health and Developmental Services and Virginia Health Information on revised regulatory language, and bring back another revised regulatory action for the board's consideration at a upcoming meeting.
All right. So let's get a motion on the table first. Is there a motion to amend the agenda?
Hi, this is Linda. I move to amend the agenda.
Thank you,
Yes.
Linda. Is there a second?
Second, this is Patricia.
One more time. Who's our second?
This is Patricia, I second.
Okay, so we have a motion from Linda and a second from Patricia. And now, comments, questions, concerns?
Hey, this is Jim.
Yep.
Just matter of clarification, is this something that is that will be brought to the next board meeting, or is it something that the commissioner might handle between now and the time of the next board meeting?
Joe, you want to take it? I think the answer to that is yes, but I'm going to let Joe take it.
Yes, sir. The objective, our objective would be to bring this to the September board meeting. That would be my objective, if all goes well. That's the plan.
Okay.
I think the goal there, Jim, if I understand everything I was briefed on yesterday, is that because of where this falls in the administration's goals and in our own, it's probably not appropriate for it to be fast track. So we will take it on ourselves. Did I get that right, Joe? All right.
Well, just one other point of clarification on that, Madam Chair. So what was on the agenda today was was fast track amendments. So a fast track action. Yeah. This requirement for regulations was contained in the first contained in the Appropriation Act in 2020, and that language in the Appropriation Act required the board to promulgate regulations within 280 days of the enactment of that, which we were unable to do. We didn't realize that we still had that option, still had that mandate to do this as emergency regulations, and we still do. It's this requirement was also in the 2021 Appropriation Act as emergency regulations. So what we will plan to bring back to the board is not fast track amendments to these regulations, but rather emergency amendments to these regulations, along with a NORA, a Notice of Intended Regulatory Action, because just as a reminder, emergency regulations are only good for 18 months in Virginia, and then they need to be made permanent. So again, the plan is to bring an emergency regulatory action with a NORA back to the board at the September meeting.
So also let me clarify that, Linda, what I believe your motion is that the agenda be amended to strike the regulatory action from the agenda today so that it can be withdrawn and presented as an emergency regulation and a NORA at a future date. Is that?
That is correct.
Okay. All right. Are there any other questions or comments? Then Alex, I'll ask that you call the roll, please.
Thank you. Mr. Kreitzer?
Yes.
Thank you. Mr. Edmondson?
Yes.
Thank you. Ms. Hines?
Yes.
Thank you. Ms. Harrison?
Yes.
Thank you. Dr. Jang?
Yes.
Thank you. Dr. Kinzer?
Yes.
Thank you. Dr. Klein?
Yes.
Thank you. Dr. Miller?
Yes.
Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Puritz?
Yes.
Thank you. Dr. Schuler? Dr. Schuler, you're on mute.
It's difficult and difficulty getting unmuted, but I am now unmuted and I vote yes.
Thank you. Dr. Swartz?
Yes.
Thank you. Ms. Waddell?
Yes.
Thank you. Ms. Whipple?
Yes.
Thank you. Madam Chair, the vote is 14 for the motion.
All righty, then our motion is carried by a vote of 14 to nothing. Alex, did you see that Dr. Pierce is here? Happy to see her smiling face.
Yes.
Okay, gotcha. All right, the next item on our agenda is the approval of the minutes from the March board meeting. Those minutes are displayed on the screen. Is there a motion to approve the minutes? Presumably you've all gotten them and read them.
Minutes on the screen?
I so move.
That's a motion from, I'm sorry, was that Wendy or Anna?
That was Wendy.
Okay. Good morning, Wendy. That is, so we have a motion to approve from Wendy. Do we have a second?
So
Anna, it's a Ken. Mhm.
Okay,
Okay.
Wendy makes the motion, Anna seconds. Are there any comments or questions about the minutes? All right, then Alex, if you could please call the roll.
Thank you. Mr. Kreitzer?
Yes.
Thank you. Mr. East is absent today, I know. Mr. Edmondson?
Yes.
Thank you. Ms. Hines?
Yes.
Thank you. Ms. Harrison?
Yes.
Thank you. Dr. Jang?
Yes.
Thank you. Dr. Kinzer?
Yes.
Thank you. Dr. Klein?
Yes.
Thank you. Dr. Miller?
Yes.
Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Puritz?
Yes.
Thank you. Dr. Schuler, we can unmute you. 1 second. You are unmuted.
Thank you. Glad to be part of this. I vote yes.
Thank you. Dr. Swartz?
Yes.
Thank you. Ms. Waddell?
Yes.
Thank you. Ms. Whipple?
Yes.
Thank you. Madam Chair, the vote is 14 for the motion.
All right, so by a vote of 14 to nothing, the minutes for March 18th are approved. I have to say, coming up on the other side of this pandemic, we are a much jollier crowd, delightfully so. Now the time in our meeting for the commissioner's report. Dr. Oliver, good morning.
Good morning, Madam Chair and members of the board. It's a pleasure to be here. And as always, I welcome the opportunity to present a report to you about what's going on in the Commonwealth. And of course, the biggest thing that's happening is our pandemic response. And my report will focus on that. We'll go to the next slide. That just outlines what I plan on touching on here. As I say, will all be focused on COVID-19. Next slide, please. Just a quick picture here shows what you all are very well aware of. The pandemic, as you see there, We were hovering around 1,000 to a couple thousand cases there from once we really got going on the spread of the disease back in April of last year. That pretty much stayed the same until the holidays when we had a big peak that reached its zenith in January of this year and has been declining since that time. And as you also are well aware, cases have been pretty low in the last period. If you've been following the numbers, our average has been over the last 7 days somewhere hovering around a couple hundred cases a day. Far cry from where we were in January and certain where we were in the beginning of the pandemic last spring. Next slide. Of course, that varies across populations and across geographies, and it's important for us to keep that in mind. The age-specific death rate for COVID-19, for example, in this as depicted in this slide, you can see that as the poverty level increases, the death rate increases as well. So in populations that are have less than 10% of the poverty rate, you can see that the death rate is 74, and it's more than double that when you have populations where the percent of the population that has high poverty levels is greater than 40%. Next slide. There's also variation in the impact of this disease across race and ethnicity. This shows a ratio of the rate of the disease in populations with the in relation to the rate in the white population. So white population is at 1, and you can see that for the Black population, the death rates are at 1.8, so like 80% more. Case rates are 1.3, hospitalization rates 1.9. The Hispanic or Latino communities also much higher rates of death, case rates, hospitalizations. We'll talk about vaccination later, but one of the things that you'll see here is that early on, we were really struggling to vaccinate the Latinx community. We're around about 0.3 ratio to that of the white population. And of late, we've been vaccinating the Latino community at about the same rate that we've been doing the white population. Likewise, we've increased the vaccination rate among African Americans, although it still lags that of whites. Next slide, please.
Norm?
Yes.
Norm, before you go, can you go back to that slide?
This one here?
Yeah.
Okay.
And you might be addressing this later, but I found it interesting that the Asian and Pacific Islander vaccination rate ratio was less than 1, but their case and hospitalization and death rate was also less than 1 to 1 compared to Black and Hispanic. and then so that's one question is how do you account for that difference? And then the other question is, as you saw increased rates of vaccination in the Black and Hispanic groups, did you start to see hospitalization and death rates going down in those two groups?
So on the first question relating to Asian and Pacific Islanders, I don't really have an answer to that. It's something that certainly would be worth looking into. And we haven't yet seen the death and case rates drop. Hospitalization rates have dropped, but that's more function, I think, of what we've seen with the spread of disease across age cohorts. People who are getting the disease are now are much younger and tend to have less severe disease and aren't getting hospitalized as much, and we're not seeing as many deaths.
Okay.
I think the case rates in African American and Latino communities are still quite high. Next slide, please. And we've also seen, of course, a difference by geography, with rural areas having a much higher both case rate and death rate from the COVID-19 disease. So those with the largest disparity were found living in census tracts with the greatest percentages, as I've already discussed, of poverty, and those with the greatest amount of rurality. Next slide. As of late May, across the Commonwealth, we've seen testing decrease throughout this period since January. As cases have declined, testing has declined as well. And this graph sort of depicts that. I'm not real concerned about it. I think that if you look at our test positivity rate, which is now around 2.1%, test positivity doesn't really give you a good idea about prevalence, but it's a fairly good measure of how well you're testing. You have a very low test positivity rate. It tends to indicate that you're testing enough, and I think that's the case. Next slide. Because vaccination is not yet available for children younger than 12, and the vaccination rates in adolescents are variable across the Commonwealth, VDH has been focusing on COVID-19 testing in schools to ensure an extra layer of prevention. The testing programs are intended to be combined with other mitigation strategies, such as mask wearing, appropriate physical distancing, and hand hygiene. And we have three specific programs that we have been implementing in the schools and working closely with DOE and with the local school departments. One is a testing pilot program. Another is a federal program called ICAT, and I can't remember what the acronym stands for. It's right offhand, but it's a testing program for the schools. And the third program is a K-12 program for to help with the reopening of the schools. That's being funded through a CDC grant that we have for the department. So the pilot program for K-12 testing provides antigen tests at no cost to school divisions interested in implementing either diagnostic or screening testing programs in the schools. And we have 7 public school divisions and 8 private or magnet schools that have received these antigen tests. More than 20,000 by next now antigen tests have been shipped out to these schools. In addition to this program, the Petersburg City Public School Division was nominated for the federal ICAT program. ICAT stands for Increasing Community Access to Testing. And it was because of the high social vulnerability scores that Petersburg City had, and so they rose to the top on that metric for the federal program. Lastly, I said that the department has a CDC grant that we're utilizing to support testing in schools. This is a grant that has awarded $257 million to provide testing for schools K through 12. And we're working with DOE to develop a program that will utilize these monies to obtain testing vendors to provide pooled testing to K through 12 schools in combination with distribution of self-test kits and resources to school divisions to hire staff to support the operations of testing programs in K through 12 schools. VDH will be collecting data on in-school testing at both private and public schools for the submission to the CDC as the grant requires. The other thing you should know is recent outreach efforts to schools did find some initial interest in testing for the 21 to 22 school year, but most communities weren't actually ready to implement this year. We continue to face challenges in this general low interest in COVID-19 testing, including in school-based programs, and this is something that's being experienced across the country. That being said, VDH and DOE will continue to conduct outreach with school nurse coordinators and continuing to outreach to superintendents throughout the summer for all three of these programs. Next slide, please. Another testing program that has been launched is depicted here in this slide. VDH, Dollar General, and the CDC Foundation are partnering to deliver testing aimed at asymptomatic individuals from vulnerable populations who are using Dollar General sites across the Commonwealth. And the main objective of this pilot program is to increase access to the testing, remove barriers, making testing opportunities more part of everyday life in these communities, and to increase the testing of asymptomatic individuals. This was launched at the beginning of this month. It's a 3-week pilot. They will offer a small incentive of a $10 Visa gift card to each person who receives the Buy Next Now antigen test. Starting during the 2nd week of the pilot. The CDC is providing 400 of these gift cards, a maximum of 2,000. 400 gift cards per day, so they'll in a maximum of 2,000 gift cards per week at each location. That you can see here, we have 3 locations around the state. So, next slide,
Can I
please.
ask a question
Yes.
about that? Hi, it's Wendy. So can you, first of all, I applaud all your efforts. It's very impressive. With this particular effort, can you clarify why we are incentivizing this testing?
Yes.
Yeah.
Yeah. So this is a CDC testing pilot. They were the ones who wanted to initiate this program, and their intention is to see whether or not using incentives will increase the rate of testing. So there's a period in which there's no incentives being offered, and then there's another period in the pilot in which incentives will be offered, and they're going to compare those 2 periods and see if there's any difference in the uptake of testing. This was the CDC's plan. We did not, this is not our study.
I question the blind testing, but I get it. Thank you.
Thank you. Next slide, please. So detecting people with COVID-19 who are infectious as soon as possible so that we can isolate them and then identify their contacts and quarantine their contacts, of course, is a cornerstone of our response to the COVID-19 pandemic. And that containment work continues. We have a workforce that peaked in October of about 1,400 people around the state and our local health departments who are working on containment. We now have about 1,200 who are still working on that. And over 50% of the people who were we identified, as you can see here, were actually contacted within 24 hours, and over 220,000 exposed contacts were called and interviewed and asked to quarantine. This spring, we have focused our efforts on what we're calling a Containment 2.0 initiative in Virginia. Major shift has been moving and promoting case investigators and contact tracers into new, more setting-specific positions that will address the current needs. As community transmission has decreased, we need to really focus our efforts more on supporting containment and mitigation in settings that like the schools and correctional facilities, certain businesses, and in other congregate care settings. And that's what we've been trying to do with this new shift in our containment efforts. So the staff will continue to, of course, to conduct case and contact tracing and follow-up, and as well as doing outbreak investigations, as well as providing technical consultation and subject matter expertise to our partners in these areas. Another major initiative that we launched early in the pandemic was the COVID-Wise app, our Virginia's exposure notification app. We promoted it and expanded its use. Since its launch last summer in August, there are now over 2 million downloads of the app. And that combines those who've downloaded the app that we produce, as well as the iOS system, the Express users, that's now part of the operating system on iPhones if you want to activate it. So we estimate that means 1 in 4 Virginians aged 18 to 65 and who have a smartphone have downloaded the COVID-Wise app, and that's a really important development. Next slide, please. In addition to the containment efforts that we have, which are aimed at boxing in the spread of the virus caused in COVID-19, we are also involved in a traveler monitoring program. The containment effort here is aimed to track any traveler coming into Virginia, and ensuring that not only COVID-19 but other diseases of interest are investigated. As you can see here, the program looks at all international travelers arriving in the Commonwealth, in that we have both district and regional staff who enroll these travelers in health monitoring programs, recommending quarantine if needed, and then testing as needed. Next slide. Part of our efforts to decrease the spread of COVID-19 is our community mitigation efforts. As you all know, the Executive Order 79 lifted most restrictions on Memorial Day weekend, and our team then released new guidance to assist businesses with mitigation decision making. We continue to advise a wide range of industries, and especially congregate settings like schools, houses of worship, and other settings, about how they can best mitigate the spread of COVID-19 in those settings. And we've updated our complaint portal to reflect EO 79, and that complaint portal remains active and will be active at least through June 30th, when the declaration of state of emergency is set to expire. Did I hear someone trying to ask a question? EO 79 requires masks to be worn by all persons on premises of K through 12 public and private schools, including teachers, students, staff, and visitors. And this is regardless of whether they are vaccinated or not. And as I said, the complaint portal still remains open. Next slide. Regarding masking, as you know, the CDC now recommends that anyone who's fully vaccinated can participate in indoor and outdoor activities without wearing a mask and without distancing in most settings. And the exceptions are the ones that I already talked about, K-12 schools, public transit, healthcare facilities, and congregate settings. The CDC continues to recommend universal masking regardless of vaccination status in those settings that I just outlined. And regardless of vaccination status, individuals must also continue to wear a mask while in public transportation. We're working to update our FAQs to help people navigate these recommendations from the CDC, and we're also providing some printed materials and signs that businesses and other establishments may use to encourage masking and distancing, especially for anyone who is not fully vaccinated yet. Next slide. Our vaccine efforts have required a massive amount of communication to explain to people the safety, efficacy of the vaccines and encourage them to get vaccinated. We've tried to use these communication campaigns to not only educate, but to build trust in these populations to get them to get vaccinated. And this slide, which you have in your board materials, outlines a number of things that we were able to accomplish in the course of the communications that we have been doing. And in fact, those communications are stepping up even more as we will talk more about the vaccination campaign, and you see where things have gone on that. Next slide. So, Danny, I see you're here.
Yes, sir. How are you?
I'm doing great. Dr. Avula, as you all know, is the state's vaccine coordinator. And we want to shift into talking about the vaccine campaign. And I think it's more than appropriate that Danny, at this point, take over the presentation, let you know how that campaign is going and where we're shifting and hit it over the summer and into the fall.
Thanks, Commissioner Oliver, and good morning, ladies and gentlemen. It's been about 5 months plus a little bit into this campaign, and much of it has felt like this roller coaster here. A lot of low lows, some really high highs, a lot of screaming, and now as we're starting to slow down, a little bit of a headache, but a lot of celebration as things have been going really well here in Virginia, and really the remarkable work of my colleagues throughout VDH, certainly at the state level and absolutely at the local levels as well, but really the entire ecosystem of providers, of healthcare workers, of pharmacies that have all banded together in a really inspiring way over the last 5 months to help get Virginia vaccinated. Next slide. Not coincidentally, the curve of our vaccination reminds me a lot of that roller coaster you saw in the last slide. One of my favorites growing up at Kings Dominion, Racer 75. But what you see here is the kind of day by day, 7-day moving average of what's happened with the vaccination effort. And while this data is from a couple days ago, but really averaging still around 24,000 doses a day. Many of those are second doses as we continue to work through the Moderna and Pfizer to ensure that people are fully vaccinated. But what you see there in April is a pretty incredible stretch where we were averaging over 80,000 doses a day, had multiple days over 100,000 doses. And then when you get to the beginning of May, that's when you see the supply and demand curve shift. And so you see that pretty striking decrease in vaccination through the first couple of weeks of May. And then the uptick. So what happened there, two things really. One, the Pfizer was approved to vaccinate adolescents. And so we got a new influx of eligible Virginians, 12 to 15 years old, who started to get vaccinated. But the bigger factor was really the CDC following the science and affirming that people who are fully vaccinated really have remarkable protection for themselves and incredibly low risk of transmitting disease. And so they changed their recommendation to allow for fully vaccinated individuals to no longer have to wear masks, and or in most settings. That served as kind of an inherent incentive for many people. And so I think the confluence of those two things, plus a lot of other things. I mean, I think this also coincides with the statewide Day of Action, a really big push that led to about 15,000 additional individuals for a couple of days getting vaccinated, and then more targeted efforts by VDH and our colleagues. And so now, as we kind of see that crest, we're now on the other side of that. It's getting harder and harder as we progress through this to chip away at the segment of our population that does not want to get vaccinated. Our hope is that these ongoing targeted efforts will start to see this curve level out. Next slide. You'll see here where much of that vaccination has happened. So pharmacies, as the federal government has really prioritized the pharmacies and the natural brick and mortar footprint that they have across the country and across the Commonwealth, we've seen them be a major player in vaccination. Really grateful for their efforts. And it's not just people coming into those pharmacies to get vaccinated. They've also been phenomenal partners in getting out into communities and doing both small and large scale community level vaccination. So we've actually, over the course of the last few months, pushed a lot of our allocation to pharmacies who've been willing to partner with health departments, partner with local governments to set up shop in different areas of need. You'll see that the next biggest is the local health departments. Our health departments from the beginning have just really all of their efforts. We've obviously hired a number of staff with federal funding, but have really dug into this work since the middle of December. And then our hospitals, our outpatient practices, and then a handful of other qualifying community providers. You can see that distribution there. Next slide. And so that leads us to kind of where we are today. The president has set a goal of getting to 70% of American adults with one dose by July 4th. You'll see here, it's a little bit small in this slide, but you'll see that 68.1%, this is a couple days ago, we're up to 68.3% as of today. But making really good progress towards that goal. And then you'll see, 8.4 plus million total doses administered, and inching now north of 46% of our population that's fully vaccinated. Next slide. Here we see the 70% goal and just how close we are to it. As I said, 68.3%, about 120,000 individuals now to get to target, and we need to average somewhere around 4,800 doses a day to get there. We, as you saw earlier, are averaging about 24,000 total doses, but closer, just under 10,000 first doses. So, at this rate, we will definitely beat that July 4th goal, and depending on how much the first dose trend changes over the next few days, I could see that happening as soon as a week out, and it could be more 10 to 12 days out. But know that we're tracking there. Our teams continue to work really hard on the ground to make vaccine more accessible, to lower the barriers to entry, and to try to get to places where people are, to go to places where there's a lot of foot traffic, and pairing it with events like festivals or sporting events. There have been a lot of really wonderful, innovative examples by our local health districts to get out and do mobile vaccination. Next slide. So here's a distribution of how we're doing, and what you see is a pretty linear association with age. Those folks who are at highest risk because of age, which often tracks the underlying condition as well. You see that 65 and up group, we've had over 80%, more like 86% actually, with at least a first dose. And then as each age category drops, you see a lower range of uptake. And I think, as I look forward to the next few months, obviously we want to continue to do work on older adults who have not yet been vaccinated, but that work is going to become more and more difficult. And so a lot of our efforts have shifted to this younger population. Now, as you look at the 12 to 15 and see that we're about a third, remember that we've had less than a month of eligibility there. And so 30% in about a month, I think is pretty good progress. We've had great partnership from our schools, a lot of on-site vaccination going on in schools, and then a lot of parents taking their kids to pharmacies and private providers. We've really ramped up enrollment of pediatricians and family practice docs to meet the need. But it's the biggest body of work here is in that Gen Z, that 16 to 30 age group where we have under 50% uptake, and so a lot of our effort really is shifting towards how do we engage them, how do we communicate the value proposition for this group, and I'll talk a little bit more about that. Next slide. And actually, you can skip this one as well. A couple of slides here just to talk through, what has our strategy been? It was March, I think, the last time we got together, and so a lot of these things were just ramping up, but the effort has been really robust. And I mentioned certainly our state central office VDH-led effort, but we really could not have done this without our other state agency partners. VDEM has been arm in arm with us since the beginning of the vaccination rollout. Other state, we've kind of pulled people from all segments of state government because this has really just been an all-encompassing response. But here you see a picture of Virginia State University, where actually, I think this is the Arthur Ashe Center, but the headline that this article came from was talking about some of our community vaccination centers across the state. We leveraged federal FEMA funding to stand up large-scale mass vaccination centers where in some places that was about 5,000 doses a day, others 3,000, others 1,000. We kind of tailored them to the volume and the communities that they were serving. But really just a daily presence for these centers to increase throughput and really maximize the number of people that we could get through for that, kind of February to March crush as allocations started to come in. So this was an early headline, but ultimately ended up with 10 different community vaccination centers. We've closed some of them as demand has dropped off. There are a couple that are still in operation, but they will be closing up around June 26th. Next slide. Over the course of the vaccination, as vaccine became more plentiful, we tried a lot of different things to reach a lot of different populations. One of those successes was moving from a registration process where you had to go to the state website, kind of sort by risk category. And then we really wanted to, we recognized that presented a barrier for segments of our population who either weren't computer literate, didn't have internet access. We did create a statewide call center to be able to help those individuals navigate, But we also know that that's just not going to reach everybody. And so walk-up vaccinations became a large part of our strategy. This continues today. And so we have teams of outreach workers who are out connecting with different communities, driving them towards vaccination sites where they can walk up, register on site, and get vaccinated at that same time. One of the big efforts this started with was when the federal government helped support a large-scale vaccination center in Norfolk. And so this is one of the early successes that we saw with our walk-up vaccinations. Next slide. Community partnerships, additionally, were one of the keys to us getting to where we are. We had not only our local health departments really connected in the communities, but we brought in additional help. We contracted with Elite Business Strategies, a minority-owned operation that really excels in community outreach and engagement and canvassing. We deployed other parts of our state government. Deputy Secretary Tracy DeShazer led a lot of those efforts in our community engagement and really kind of connecting with different organizations and different entities around the state. Faith communities were a very key part of that, not only talking about vaccination and helping people navigate the process to get signed up, but in many cases hosting vaccination efforts on site in churches or deploying their resources like their church vans to get their congregants to mass vaccination sites. Really could not have done it without the extensive network that VDH and all of state government have built with community partners. Next slide. That certainly was true in our Christian faith communities, but there were many examples of reaching beyond that as well. And here's an example in the Tidewater area of Centera partnering with Islamic faith leaders to really think about the unique circumstances here, highlighting the barriers around Ramadan and people who had not eaten all day, just being sensitive, extending hours to be able to meet the needs of subsets of our population. Next slide. So in addition, we did a lot of, we simultaneously set up the mass vaccination efforts to get as many people vaccinated as quickly as possible, but we also recognized to really get to our most vulnerable communities, our African-American and Latino communities that we'd seen throughout the pandemic over the last year had higher rates of hospitalization and death. We knew we needed to design targeted efforts to reach those communities. And so with the sort of innovative approaches of local health departments, the added support of groups like Elite, we were able to set up a number of examples of where we're targeting different communities, going into neighborhoods, going into churches, working through refugee networks to really try to expand our reach. I think there, as Dr. Oliver mentioned earlier, there's been a lot of success in the Latino community in particular, but we still have a long way to go with our African American community. And so that continues to be an area of focus for us. We'll talk more about that in a second. Next slide. Other barriers. I mean, I think we just at every step of this have had to think about what is keeping people from being able to get vaccinated. Because while there's a subset of the population that doesn't want to, right? They've chosen not to get vaccinated for various reasons. There are lots of really practical reasons that people aren't getting vaccinated. I mentioned computer access, phone access, literacy, but transportation barriers were another part of that. And so many of our providers were really thoughtful about ensuring that our vaccination outposts were on bus lines, working with local partners to help, like churches, to help people get to these events. Lyft and Uber became a part of that as the federal government brokered a relationship with them to provide free rides to people wanting to get vaccinated. And the next slide. And as we recognize the barriers of transportation, the next slide really shows us the move into mobile clinics, which, I think along the way, many sort of small efforts to do mobile in communities, and then this has become a much bigger focus in this stage of the vaccination effort, where we actually have contracted vendors who in rural communities have kind of set up outposts, really led but with the direction of our local health directors about what communities we need to get into, taking a really data-driven approach about what communities have not had access, or have we seen higher rates of COVID in, or have a higher concentration of marginalized populations. Here's a great example of partners that had mobile units that came alongside us in these efforts here at Virginia State University. Back to the concept of reaching certain marginalized populations, we also recognize that our communication strategies, our shareables, the things we were developing had to take that into consideration and really be reflective of the populations that we want to serve. Next slide. So we collectively hired, we have a few different communications vendors, but one of the ones that we use is a Black-owned business called Green Street Communications. And you'll see just a few examples here of the type of work that they did where they really prioritized, African-American health providers, having Black and brown faces be a part of that work and targeting campaigns to ways that connect with those communities. Next slide. And we can kind of run through these pretty quickly. Here's one that aligns to celebrating Diversity Month. Next slide. One that kind of centers us on our ongoing work around equity. Next slide. A specific campaign here that really targeted at barbershops and beauty salons. Next slide. And then another example of developing a Mythbusters portfolio, because there's so much, so many myths out there. People have a lot of questions. There was a lot of kind of contradictory information that was being circulated around the internet. Actually, I'm going to pause right here. I see that there might be a question from one of the board members.
I think Catherine had her hand up. Catherine, did you have a question?
Now I'm unmuted. I just wanted to ask about the COVID-19 variant. I heard Dr. Fauci say that you have to have both, and I know some people have only had one dose of the vaccine, and that you need two in order to be protected from this variant. How are y'all handling that situation?
Yeah, it's a really important point, Catherine. It's been a big challenge during this whole effort to ensure that people understand the importance of being fully vaccinated. So just, I think probably most people know that Johnson & Johnson is a 1-dose series, Moderna and Pfizer are a 2-dose series, and you have variable levels of effectiveness with 1 dose versus 2 doses. Early on, 1 dose seemed to be pretty effective. It would get you to somewhere between 70 and 80%, and then you would reach about 95% protected with that second dose. As we've seen more enter the equation, and they are the predominant presence of virus in our country right now. The UK variant is about 70% of circulating virus. The Indian variant, the Delta variant, as it's called now, is about 6% of circulating virus. And we have seen a few cases of that here in Virginia. But the concerning part is that 1-dose efficacy in some of the early studies shows really low effectiveness against variants, somewhere between 20 and 40%, depending on what variant and what study we're talking about. And then if you get to full protection, so 2 doses 2 weeks after, that gets you somewhere in the 80s against many of these variants. So the good news is that the virus seems to be very effective against the variants that are predominating right now. The concerning news that you're bringing up, Catherine, is that we do have a number of people who chose to get their first dose and who have not gotten their second dose. And there's a lot of different reasons for that. I think primarily that is because people, maybe who were hesitant about it in the first place, got their first dose, maybe had some of the side effects of fever, some achiness, and then said, well, 1 dose is probably good enough. We need to. I'm okay. So we are leaning into how do we make sure we're following up with all of those individuals. We actually did a call out campaign with our call center where we called all of the people in our state registry who had 1 dose but not a second dose to ask them why they didn't get vaccinated and try to plug them in. That was only marginally successful. I mean, I think there are a lot of people who just were didn't feel good or didn't want to go and get that second dose. So there's a lot of work, and hopefully what you bring up is going to be a new incentive or a new motivation for people to go and get that second dose. But it's something we're paying attention to. It's about 8% of the people that have gotten their vaccine, or 8% of people who have gotten the first dose of a 2-dose vaccine who have not gotten a second dose, which approximates to around 160,000 last time I checked. It's probably a little bit more now.
All right. Thank you.
Yeah, no problem. Next slide. So, that Mythbusters campaign that you see there is really because there is a remarkable amount of misinformation out there. And it's important to raise awareness about the fact that this is not accidental. It's not sort of kids just putting stuff out there, although that happens in some cases. But there is actually a very intentional and strategic effort by people who don't support vaccination to spread these messages. And so here's just a couple of examples. One, there are a number of social media influencers who have millions of followers who have been paid to promote misinformation and disinformation. This is a very real phenomenon. This disinformation dozen was done by a national think tank where they actually looked at anti-vaccination rhetoric being passed around social media. And what they found was that 65% of the content that would be described as misinformation emanated from 12 specific users. And so, the anti-vaccination contingent is being very intentional about spreading these messages. And so it's really important for us to know and understand that and to craft our communications efforts in ways that prevent against that. Next slide, just one more example of the misinformation. Now there are actually bots, so not even real people, but programs that are written to continue spreading these COVID untruths. And so when we think about, why is it that we're not seeing more than about 50% right now of our population with being fully vaccinated, or close to 70% with 1 dose? This is what we're up against. And so the game has changed. We've got to try different strategies, and it's gonna be a lot harder, and it's gonna go a lot slower because it requires this very, very directed one-on-one work in communities, and that takes a lot of time and a lot of resources and a lot of energy. Next slide. A few examples of some of the misinformations or myths that people are facing. This was a Kaiser Family Foundation has done this thing called the Vaccine Monitor, where every month they're resurveying populations. And what you see here is a survey of unvaccinated adults. Why have they not gotten vaccinated? They still are concerned. They think that there's truth to the fact that you can get COVID from the vaccine, that the vaccine is associated with infertility, that the vaccine contains cells from aborted fetuses, that you don't need to get the vaccine if you've already had it, or that the vaccine somehow changes your DNA. So these are some of the leading myths that we're seeing out there. And so this all kind of speaks to, next slide, the importance of healthcare providers. We know that survey after survey shows that people trust their healthcare providers. They trust their doctors or their PAs or their nurses. And so, next slide. So we really, at this point, as we've moved away from the mass vaccination delivery, sorry, the slide isn't showing up for me. I don't know if it's showing up for you guys or not.
I can see it, yes.
Okay, great. Now it's up. So, in one survey, 73% of unvaccinated adults said they trust their physician's opinion about vaccination, but less than 20% have actually heard from their docs or been encouraged by their docs to get vaccinated. And so for this remaining segment of the population, a huge part of our strategy has to be compelling our providers to be proactive about these asks. In just the same way as years ago, we made smoking one of the vital signs, right? As clinicians, we would ask patients, are you a smoker? We need to start the same kind of campaign for healthcare providers to do that now. Have you been vaccinated? If not, why not? And how can we facilitate and position providers to be really effective in that effort? Couple of other thoughts on here. I've mentioned that people are clinging to a lot of common misconceptions. So next slide. Here's where the work kind of lays out for the next few months. We've gotten to most of the people who want to get vaccinated. I think there's still a segment of the population who will get vaccinated as we make it easier to do so, as we show up at festivals or sporting events or places of employment. When it's there and it's in front of you and people are encouraging you to do it, we're going to get a certain segment of the population who chooses to do it because we've made it ultra convenient. But there is a targeted effort with a bunch of groups that I've outlined here. So healthcare providers, we still have a lot of work to do with the African American community. We see a lot of frank resistance, largely due to the politicization of the entire COVID pandemic in rural Virginia. Law enforcement and public safety have shown much lower rates of uptake than other segments of the population. I actually was just presenting to the statewide Association of Sheriffs yesterday evening in Williamsburg, an in-person event, about 300 sheriffs and their deputies. I think that the reality is that people are tired of COVID. They're tired of hearing about vaccination. They feel like they've pushed it with their staff so far, and they don't feel compelled to keep at it. And I think the concern that raises is that if we're only getting to somewhere between, when this is all set, this wave is all said and done, 60 to 70% fully vaccinated, that does leave a window for a resurgence in the fall or for these variants to take hold. And so we really need to keep at the message of community immunity. We need to get to that herd immunity threshold of somewhere between 70 or 80%. And that means getting a lot of individuals who don't necessarily feel the threat of COVID themselves because they're young and healthy, that they need to see a value proposition that goes beyond themselves. Protect yourself, yes. Protect your family, protect your community.
Danielle, can I ask one question?
Absolutely.
Yeah, you got a really good point, to get a healthcare provider be part of this, vaccines campaign. My question for you is that, is primary care will be available to provide a vaccine? Did you plan to do so?
Yeah, thanks, Dr. Chang. So primary care providers have definitely been a big part of the vaccination effort so far. If you look at the earlier slide, there's a big chunk of our vaccine delivery that has happened through medical providers. Now, early on, and I remember at our last meeting, there was a lot of concern that primary care providers hadn't had more access to vaccine. And as I engaged many of those groups, the Medical Society of Virginia, the Virginia Association of Family Practice Docs, ACP, my message to them was that at this stage, this was kind of February, March, we have limited supply and we need to focus on equity and efficiency. We need to get it out as quickly as possible to as many people as possible, and we need to do it in really targeted ways that get it to our most vulnerable populations. And I reassured people, I said, there will be a time as supply increases that we absolutely need providers, because we know that providers have that trusted relationship with their patients.
Yes.
But it is slower and kind of, that one-on-one work with patient. And so over the last month, that's where we've really made the shift. We've seen supply become plentiful. We've re-engaged our private providers. And then a few other things that have changed to help support private providers' ability to deliver vaccine. You may remember that Pfizer in particular, but there were handling issues around all of the vaccines, but Pfizer required ultra cold storage, so negative 90-degree temperature that a lot of smaller providers didn't have access to. They also were shipped out by the federal government in trays of 1,170 doses, which was way more than a lot of small providers could actually handle. A lot of that has changed as the manufacturer has studied the efficacy of Pfizer vaccine in different settings. About 2 weeks ago, Pfizer announced that their vaccine can now be stored in refrigerated temperatures for 30 days. So that has made it a lot easier. And in addition, Dr. Stephanie Wewell, who runs our state pharmacy, her team has created a central kind of redistribution program. Well, we will take that 1,170 doses of Pfizer and we will chop it up and allow providers to order just a few vials if that's all they need. And then the last thing that has made it easier for providers is that For the first 4 months of this, our messaging to anybody who was receiving vaccine was like, we need to get it out as quickly as possible. Every dose is precious. We really need to, use the inventory you have, because if you're not, that's people who want vaccine who can't. That we're at a different stage, right? There's much more supply than demand. And so even the CDC has really changed their messaging to say, some degree of wastage is acceptable. We need to make sure that we do not miss an opportunity to have the patient in front of you get vaccinated, even if it means opening up a multi-dose vial. So over the last month, we've really changed our messaging with our private providers. We're at a different stage of this, and it's been a lot more flexible. And so that's led to kind of a rebound and increase of private providers who have become approved. And then one more thing we've done, if you go to the next slide, this week last week we sent this out to providers, our teletown hall initiative. So we created a platform for providers to address their entire patient populations at one time. VDH staff will help facilitate a Zoom platform. We've provided a PowerPoint template and a list of FAQs for providers who may just not be up to date on all of the latest myths and how to address them. And so we're testing it this week, and we sent this out last week to see if and then a follow-up survey to see if we can find a number of providers who want to participate to address not just an individual patient at a time, but really their entire patient panel simultaneously. And hopefully that will drive more and more people. And it's critically important that not only are they asking their patients, addressing their concerns and reassuring them about vaccination, but that they also have vaccine on site so that they can schedule those appointments and get patients in to vaccinate them.
Danny, if I could just interject one other thing here. I don't want to lose the importance of local governments in all of this. Certainly, VDH and the state government has done an amazing job, but the local governments can help to kind of cross that divide where some of those at-risk populations are. And I think that the local health districts in areas where local governments have been involved have had higher populations of vaccinated adults. Certainly I have a vaccine resistant county, but we partnered with our local health district and opened and paid for a vaccine clinic. My sheriff, who I'm sure you probably met yesterday, two things happened there. One, he got a lot of calls from elected officials saying, we hear your deputies aren't masking all of the time. And so our deputies are masking all the time. And then the second thing is our sheriff got COVID, and now he understood exactly how serious it was.
Wow.
But he also asked us as elected officials to tell people that. And so we have a kind of a broad reach into the community. We have our sheriff's department has a interaction with all of our African American churches in our county. So local governments often have their fingers in a lot of pies and have access to a lot of these resistant folks. So I don't want to forget the importance of that partnership, because most local governments are very willing to be used, touched, and needed for this.
Yeah, it's a really great point, Chairwoman Pritchard. I think you're exactly right, and I think all the local health departments have been pretty connected to local governments, but I think you're right. There's a real opportunity to go back to them and see how they leverage, their oversight and authority in different spaces. Actually, Craig Pfeiffer and we've been in contact with our mutual colleague Jim Taylor about presenting to VLGMA next week, I think, about vaccination efforts and how local governments can help. So hopefully that generates a lot of opportunities for local governments to step in. But thank you for raising that really important point.
Dr. Avila, I do have one more question. This is Catherine. I wanted to ask you about people that are working in hospitals and in doctors' offices who refuse to be vaccinated. I happened to be in a doctor's office in a hospital where my husband was getting ready to have heart surgery. And the nurse that was in there told me that it was her choice not to have the vaccine. So how do we respond to that? And how do you counteract that?
Yeah, it's a tough area, particularly with healthcare workers. I think some health systems have already moved to requiring vaccination of their staff. This has certainly been a nationwide trend. In fact, there was a headline a couple of days ago that University of Pennsylvania Health System put a number of, I think, can't remember how many, but a significant number of their staff on suspension who had opted not to get vaccinated. I imagine that trend will continue as the stakes continue to be really high in a vulnerable, hospitalized inpatient and outpatient population. So that will be one trend that I see increasing, is that health systems will start to require vaccination. I especially think that's true after, all of these vaccines are still under an emergency use authorization. I suspect sometime in the next 3-ish months, probably by the end of the year at the very least, we'll have a fully licensed vaccine by the FDA, and that will allow a lot of entities a lot more legal confidence to be able to require vaccines. So that's one of the biggest things I see. But we are also continuing to network with our healthcare providers. I mean, I just look at my calendar for the next 2 weeks, and I've got Medical Society of Virginia, VAFP, VAAP, and I'm meeting tomorrow with the chief medical officers of the health systems, where we'll certainly address some of these issues. So, I don't know that we at the state level will have a role in any requirements at all, but certainly encouraging and supporting private entities to pursue that.
Thank you.
Mm-hmm. All right. I think there's one more slide on here is just an example of what I shared with the Virginia Sheriff's Association yesterday. I can just show it to you real quick, but this is an example of where framing the messaging is really important. And what this shows is that there was 254 total deaths among law enforcement professionals over the year of 2020, and 145 of them were due to COVID. And so really way outpacing any other cause of death for law enforcement professionals on the front line, and a couple of examples of sheriffs here in Virginia who passed away due to COVID. And I share this just to say that this is the kind of work that we've been doing this last month and will be for the next few months, where we find these targeted segments, the ones that I listed on the previous slide. We identify the optimal communications approach. And again, it's going to be much slower and harder work, but that's what we've got to do to get to community immunity. So thanks so much, everyone. Really appreciate your attention. Happy to answer any other questions.
This is Anna. I just want to say, thank you, Danny. You call in to serve in a critical time, and evidently, government has such confidence in you, and I think he really picked the right person with short period of time. You have made such contributions to this vaccine campaign. I just want to personally thank you for your service.
Appreciate that, Dr. Jang. I'll just say I was jumping on a train that was already moving. I mean, it's been amazing to work with the team at VDH, and really it's taken all of us. Like, it's been a really remarkable 5 months, and I'll stick around for a little while. I'm not completely going to disappear, but yeah, it's been an all hands on deck effort.
I think we'd like to all echo what Anna has said.
Absolutely.
Your name gets invoked in 1 out of 5 conversations I'm in local government, and it's always with a great deal of respect and gratitude.
Thanks, Faye.
I just have to add that and Dr. Avula, you have been, I can't thank you enough for your leadership, but Dr. Oliver and the entire VDH team and the VDEM team, I've had the privilege of working with some of these efforts. I am so grateful to the entire team, and the work you all are doing has been remarkable. So thank you.
I think Linda Hines has had her hand up for a bit. I'm sorry, Linda.
No, that's okay. Actually, Catherine asked somewhat of a question, and Dr. Avula actually went in that direction. I was going to ask if we thought that the vaccine would become required for certain activities, for certain interests into school, like some of our other vaccines, but he did address that, because it has emergency use authorization at this moment. and not full authorization. I think we may see that coming is what I think I heard from you.
Linda, one other place I really see that ramping up is institutions of higher education.
Yes.
A few weeks ago, the Attorney General actually, sort of sent out a decision saying, IHEs do have the option to do this. There's plenty to support that. We've seen about 13, I think, here in Virginia, about 500 nationwide. But I see that as a trend that will continue as well.
I also have one more question. Was about the vaccine policy for business. I know it's more about OSHA. OSHA's one to determine for occupational safety and health, but I think BDH also play a role in that. So I wonder if BDH had discussed any of in terms of for that masking, all of the policy to do with how the business operates. Business also include our academia. And so I just want to hear your comment on this issue. Go ahead. Yeah.
Yeah, well, there's definitely a big employer engagement component of this work right now, both on the vaccination and certainly because we recognize that employers have a big role. And the approach we're taking right now is 3 things that we're asking employers to do. One, to recognize that ongoing communication, ongoing encouragement about the need for vaccination from an employer to an employee is really valuable and will continue to stoke interest. 2, to actually host on-site vaccination at their places of employment. As we've talked about the need to just lower access, to make vaccination convenient, we want to work with employers to create recurring on-site vaccination opportunities. And 3rd is in the area of incentives. The state is still really wrestling with what is our role. There's a lot of differing perspectives on the role of incentives, and particularly the use of taxpayer dollars to incentivize a behavior that we need now, but we're going to need in the future, right? Boosters are around the corner, future vaccination efforts. Is that the right precedent to set? And is it making a lasting difference in other states? I'm regularly in contact every week or twice a week in some cases. I'm with vaccination coordinators from across the country. And so we're looking at these things. We're looking at how Ohio and California and Washington's lottery efforts are impacting uptake. North Carolina started last week a $25 gift card incentive. So we're monitoring it. I think there will be a little bit of movement in that direction, but I think the private sector has already moved in that direction, right? There's tons of examples of national and local businesses that have started to offer their employees. So Kroger is a good example. From the beginning, they were offering their employees $100 incentives to get vaccinated. And that has really expanded. So that's the vaccination piece of this. I might defer to Norm or Lori on kind of the office workplace mitigation requirements.
Okay, I think Gary has something too.
And also Jim waving his hand on camera.
All right, well, we'll get Gary first and then Jim in a second.
My question was related to the changes in the executive orders, and this is probably more for Dr. Oliver. As you know, that one of the executive orders authorized individuals to become vaccinators that aren't traditionally vaccinators. For example, in the Code of Virginia, advanced EMS providers, paramedics, for example, are allowed to administer vaccines. But through the executive order, additional EMS providers, all the way down to the basic EMT level, were allowed to become vaccinators. With the relaxation of the executive order, allowing those to expire, is there any efforts underway to continue to be able to utilize those non-traditional vaccinators until we get through this vaccine rollout?
Gary, thank you for that question. There was some legislation, as you might recall, in the last session of the GA that expanded who could be vaccinators. It did not address this issue of some of the EMS and paramedics and so on. I think that there's a definite appetite for that, and it's the sort of thing that we will be discussing with our colleagues over at Department of Health Professions and see what we can do about having having an expanded workforce for doing vaccinations. There's a lot of situations where you all will be able to reach some populations that we would not be able to reach, and I think it's worth looking into.
Yeah, I would agree, and I thank you for that. Certainly we've always had the ability, or at least for the last 5 to 8 years, for paramedics to vaccinate, but the large number of EMS providers in Virginia are not paramedics. They're EMTs and advanced EMTs. So having those additional resources in a crisis like this, I know in my neighborhood up here, working with the Central Shenandoah Health District, we've used a lot of EMS vaccinators, and it's been a really good partnership, and we just don't want to see that go away.
Yes. Madam Chair, there was another question from
Jim.
Jang.
Oh, sorry.
From Dr. Jang related to the employers and mask guidance on that. And our community mitigation team has been putting out some guidance on that. Dr. Forlano, I believe, is on the line, and she and others in that mitigation team have been really the main ones helping to put out that guidance. So I'd ask her to, if she's here, to address that aspect of Dr. Jang's question.
Well, thank you, because it's been kind of confusing for the business in terms of vaccination and masking. So thank you for addressing that question. Thank you.
Dr. Forlano, are you still here? Lori? Well, if she comes back, we will go back to her. But in the meantime, Jim has his hand raised, and then Benita is after that. So, Jim?
Hi. Just an excellent report. I'm delighted with all of the variety of measures that are being taken to try to achieve the goals. And that really is the basis of my question. What have we learned from this successful rollout of the vaccination process that we should apply in delivering services to underserved communities around the state when the press of vaccinations is over? We know that certain populations just aren't getting diagnosis and treatments the way we need, and we've got methods. We've identified methods in the vaccination rollout that seem to have some success. Can we employ them in 2022 and beyond in the delivery of services?
It's a really, really important question for everything that we're considering right now, Jim. I think Norm is leading VDH's effort to envision what is this health department of the future? What are the areas that we really need to invest in and build up so that we can do exactly what you're talking about? There's two things that come to mind immediately for me, and I'm sure Norm has lots of other thoughts on this. One is the investment in our communications arm, right? I think a lot of our work at VDH has been our communications work has been responsive to media requests. We're even outside of COVID, we're always getting media requests around different health issues. But the sort of proactive and strategic communications work that we've really invested in and seen the fruit of during this season of COVID is something that should always be a part of what VDH is doing. And then secondly is the outreach and engagement component. I think the benefit of having contractors like Elite, of being able to hire outreach workers and community engagement workers, and to have not just in the context of an emergency, but to have long-standing relationships with key communities. That's where all of our work in public health should be. And so I think that the local health districts have seen that in a different way. And hopefully some of these new federal funding streams will allow for longer standing investments in building that community engagement and community outreach infrastructure on the ground.
Yeah,
Madam Chair.
Oh, I'm sorry, Norm, go ahead, I'm sorry.
Yeah, I just wanted to address that a little bit too, Jim. As Danny mentioned, we're currently having a discussion within VDH, and this is a discussion that health departments across the country are having. There's a lot of funding coming out of federal government to help us on the COVID-19 response, and this is, of course, very welcome. And there's more money that's coming through ARPA, and you'll hear a report on that later on in the agenda. And what we want to do is to use these monies very strategically. We don't want to just take the money and put it into our sort of standing programs and go from there. This is a chance to build back better public health, right? It's been under-resourced, understaffed for quite a long time. The fractures that you saw in the response to COVID-19 here in the Commonwealth and across the country, in part as a result of that, right? All kinds of things like our ability to collect the data that we needed, to report it in the most efficient manner. The communications issues that Danny just talked about. There's so many aspects of what we do that we need to build up that infrastructure, and we're going to utilize these monies to do that and put us in a position to not only sort of set that foundation, but we're also talking about going to the GA and to the state government and saying that there needs to be an investment in public health that allows public health to be sustained at a high level, not to be ready for the next pandemic, right? Because in public health, we always said it's not whether there will be a pandemic, it's when will we have a pandemic. Unfortunately, we got one, right? And it's likely that at some point we're going to get another one. And we need to be much better prepared for it than we were for this one. So.
Like Oliver and you both you're really, right on the money. In fact, that was my 2 or 3 my recommendation how to use the money from American Rescue Act. It's about the communication, build along these standards with the local government and local Department of Health. And so, yeah, I fully support that. Yes, you're right on the money. Yeah.
I'm sorry, Jim. Like you had a second part to your question.
Well, you've really hit the gold mine, I think, about getting ourselves ready for the next pandemic. But I want to reemphasize that my additional concern is in our using funding, hopefully much greater funding for public health generally, to find ways to reach the unreached. Not just related to vaccines, but to actually delivering services, dealing with their chronic conditions, getting them to see healthcare professionals in a way that they haven't, and that needs to be built into the I think an updated version of VDH and the local departments. And getting that resourced won't be easy, but we need to just be pushing that as policymakers, as advocates, and the more the better.
Well, thank you for that, Jim.
I think Benita is next.
Madam Chair?
Yes, yes, sir.
I just wanted to address that business question that is still hanging out there from Dr. Jang. So I'm going to drop into the chat the URL for the recommendations that VDH is providing to businesses. And, the number one thing we're doing is as Danny talked about, we're encouraging employers to encourage their employees and their patrons to get vaccinated, and providing them with information and flyers and posters and all kinds of things to help them to do that. We've also asked and provided guidelines for them to establish a mask wearing policy for employees. At a minimum, it should be what the CDC recommends, which is that people who are fully vaccinated do not need to wear masks, and people who are not fully vaccinated ought to wear masks. But employers have the ability to have more strict guidelines for their places of employment. You've already heard about the fact that some universities are increasingly requiring vaccination. And that could be also true in terms of mask wearing. Businesses could say, no mask, no entry, right? Or whatever. And there are some places that actually are still requiring that, and they could require that of their employees as well. So anyway, they can establish policies around mask wearing. They can establish policies and practices around physical distancing and other hygiene, like hand washing and so on. And they can also continue to do things like routine cleaning and disinfection sorts of procedures. So they have a lot more leeway, I think, and these guidelines provide them with some suggestions on how to do that. And as I said, I'll drop that into the chat so that people can take a look at that and read it on your own.
All right, thank you for the information.
I actually have a follow-up question for that, Norm, but Danny has a heart out on us, so I want to make sure. Benita, is your question for Danny, Dr. Agula?
It is, yes.
Okay, well then I will let you go first.
Okay. Well, and very quickly, I do want to thank you for the Herculean effort by you and the rest of the Department of Health, because it is pretty amazing what's been accomplished, and going into communities and reaching people who can't get out is so critical. So thank you for doing that. And to follow up, Jim, I think it's a great opportunity to see, is this a process or a way of reaching people long-term for their other health needs? And then so then my question is kind of totally on a different thing, but sort of related. It's regarding a booster shot, in light of, we don't know exactly how long immunity might last, and with variants coming in. So when do you envision we might have a process established for a booster shot, and do you envision kind of following the same tactics that you're doing now for a booster, or do you see a different path for that?
Yeah, thanks, Benita. I do think it's very likely and almost certain at this point that there will be a booster on the horizon. I think the two issues that dictate the timeline for that are, one, how effective are our current vaccines against the variants? And so far, the preliminary data has been really good. And two, how long does vaccine-mediated immunity last? And that's where we just don't know enough yet to know, are we looking at a year of protection with the various vaccines, or is it shorter? Some of the national experts have said, we probably are going to see a booster by the end of the year. Others have said we won't need that until later into 2022. But the fact remains that is very, very likely on the horizon. The question about how will that be delivered, and will we need this same level of vaccine delivery infrastructure, I think is an important one that we're thinking through right now. My feeling is that the existing infrastructure of pharmacies, private providers, and then the safety net, health departments, free clinics, federally qualified health centers, will likely cover most of that need. I don't know that we're going to have to set up large-scale mass vaccination again, because remember, the context when all this started was devastating. I mean, we really had a pandemic at the peak of its viral circulation. We had no protection in most cases. And so this is a different scenario. I think the fact that we have had so many people vaccinated means we're likely not going to see the same surge of disease that we saw last December and January, and that people will have varying levels of immunity that are kind of waning at different stages. So my gut is that we can rely on the existing infrastructure for delivery. I think we will need this sort of increased infrastructure on the community engagement and communications work, but won't have to be as solely responsible for the mass delivery of that vaccine. Thanks so much, everyone. I've got a group of pastors waiting for me that I need to convince on how to engage their congregations around vaccination. But I really have enjoyed the time with you all, and we'll see where we are at the next meeting if I join you again. But thanks so much. Take care.
Thank you so much.
Thank you.
Take care. Norm, my follow-up question for you is about, we're back to the employer-employee question. So one, first of all, I am still seeing everybody in the world wearing a mask. And everyone I know who is fully vaccinated is still wearing a mask in places, in congregate settings like the grocery store. And it's actually been kind of, I don't know, inspiring to me that people are still just like, I'm just going to be careful a little bit longer. But the question I have is about employers and what they're allowed to do really with their employees. So it's two-pronged. So can I, as an employer, can I make my employee disclose to me if they have been vaccinated? Is that a First Amendment issue? And then the second prong of that is I read this week that there is, of course, already a black market for fake ID, for fake vaccination cards. And do we know what federal and local governments are doing in terms of combating that particular onslaught of fake vaccination cards?
So I'm not a lawyer, so I'm not going to try to tell you anything about the legal sort of issues here involved with employers and their employees. I do know that the owner of a business can set guidelines, like such as, you want everyone in the business to wear a mask. Whether or not they're vaccinated, right? You could just say, as the owner, that's what's going to happen in this setting. But as far as asking whether or not people are vaccinated, I don't know that the sort of legalities around that. The guidance from the CDC, as you know, leaves that up to the individual. So if you as an individual are fully vaccinated and they have recommended that you don't have to, but you may, if you want to, wear a mask. And as you said, most of us who are fully vaccinated still carry a mask or masks with us all the time, so, but for those situations where we feel more comfortable having a mask on. And then if you're not fully vaccinated, it's you ought to, or it's suggested that you would wear a mask. I don't know if Robin or one of our
I just texted her. I just chatted her.
Is here to speak to the legal issue.
Dr. Oliver, do you know if the state's looking at vaccine passports?
No, we're not looking at that at this time.
Dr. Oliver, usually in this Occupational Safety Health Administration said the guideline will, regulation to do with the workers, the health injury. And in this case, I was wondering if VDH have any communication with ASHA. I know they're very slow on developing any of the guidelines and the regulation to do with the vaccine. And I was wondering if VDH had any communication with ASHA. about this, particularly to do with business, because that was related to the workers' health and safety in terms of the weather.
So we participate on the Health and Safety Board of the Department of Labor and Industry, which provides those sorts of guidelines. And in that way that we collaborate with them in developing those that guidance for businesses. Our Office of Environmental Health Services is headed and directed by Julie Henderson, who's here. Julie can speak both to this question of OSHA and DOLE and what how we've worked with them on these guidelines, as well as some of the broader issues of community mitigation that have come up in this discussion. So I'll kick it over to Julie if she's online.
Hi, Dr. Oliver. Yes, I'm here.
Okay.
And I just rejoined the meeting, so Alex is catching me up a little bit, but I'm happy to answer any questions as it relates to the application of our current executive order and our work with the Virginia DOLE and Virginia OSHA.
Well, there was a question specifically around businesses and what businesses can do in the way of asking employees about their vaccination status and what sort of guidance we're giving them on policies and practices around mask wearing and other mitigation measures in their places of business. I did drop into the chat the link to the general recommendations for businesses that we put out.
Oh, thank you. Yeah, so as you all are aware, Executive Order 72 expired and that was replaced with Executive Order 79. And when that happened, requirements for businesses essentially went away when it came to the mask order requiring patrons to wear masks, and also restrictions related to like physical distancing and setting up, say, a restaurant and having specific seating requirements and that they couldn't use the bar seating and things similar to that. So what we've done now is kind of shifted more over to making recommendations and providing resources for businesses to use. And that includes some written guidance, but also Dr. Oliver, what you referenced, providing resources on our webpage. And then we also working with our communications group to kind of come up with posters and things. So when someone enters a business, if a restaurant continues to require masks, or they would like to remind people if they're not fully vaccinated to wear masks and as complying with CDC's recommendations, then we've provided them with updated posters and signs and things they can use within their business, both really for patrons and for businesses. We're not providing businesses with guidance as it relates to if they can ask their employees about vaccination status, because that's more of something they need to talk to their legal counsel with, and we don't generally provide them with legal counsel and really should not be doing that. So, that we're not doing. And Robin may be able to speak more to that, and if she hasn't already, but we definitely are telling our staff in the districts that that's not our role, and we shouldn't be doing that. No, we're mainly sticking to just the CDC guidance because that's really where our lane is.
Hi, everybody. This is Robin. Julie is correct. We can't give legal advice to private companies. You might want to look at the EEOC guidance. They've issued some fairly detailed guidance on how employers can and may handle the COVID vaccination issue. A lot of it centers on the Americans with Disabilities Act. The employer does have some latitude to ask some questions, but does have to abide by that law. So I think that would probably be the best resource that explains a little bit about asking about vaccination and requiring it. It kind of stops short of giving super concrete recommendations, but it does provide probably the most helpful guidance I've seen for private employers.
Robin, my question is, if you guys have any communication with ASHAs? Because I do know, as I mentioned before, ASHAs, agencies that develop and sometimes regulation and sometimes, related to legal stuff and to do with the workers' injuries and health.
I think OSHA has provided some guidance also, but no, I don't. My office has not been in direct communication with OSHA.
Yeah.
A little bit to that. This is Julie, and so Dolly was Virginia was one of the first states to have a law pertaining to COVID-19 and worker protections, and I think there's only 2 others that currently have that. We did receive a draft of an amendment for the permanent standards yesterday from Dolly, and so we're going to work on reviewing that, and then we'll provide recommendations to Dr. Oliver and Dr. Carey on our community mitigation review. And that includes requirements for employees to continue to wear a mask and potentially looking at vaccination status. But we haven't really delved into that draft yet. We just got it yesterday afternoon. But we were, again, one of the states that had that law in place, and OSHA still does not have a COVID protection law. There's not a national law.
They are very slow on that, but thank you for working on that. I think this area is needed because underground, I heard a lot of very confusing. People are very confusing about this, so it's more guidance probably. So welcome. Thank you so much.
You guys, I knew we would have lots and lots of questions today, and I think that's wonderful. We've got at least 3 more questions, and I think we all need a little bit of a break. I know I do. If we could just go ahead and take about 10 minutes, we'll keep this first break real brief. And when we come back, we will start with, I lost track a little bit. Jim Schuler is next, and then Gary, and then Mary Margaret, you're right after that, if that's okay. So let's take about 10 minutes. We'll be back at 10 after 11. And then we can finish anything that anybody else has.
Ooh.
Okay, get everybody to start moving back towards the center here. So I just talked to Joe, and our plan is this. Even with all of our questions, which is a good thing, we're a little bit ahead of schedule. So we will take our 3 questions and anything else that comes up as we go through this. And then we're just going to work through the agenda because it does look like we're a little bit ahead. And when we finish, we will break at that point until 1 o'clock, which is when Secretary Carey will be here. And then after Secretary Carey, then we will do our under other business, our voting on officers. Does that sound okay to everybody? Everybody? Okay. Well, then Jim Schuler, you are online. Happy to see you. But you're on mute. Be happy to hear you. Alex, can you help?
Press the spacer bar. Jim, press the spacer bar and hold
Alex,
it down.
Alex, can you unmute Jim? I don't have that capability.
I think I got it now.
Yay, you do.
Thank you, Madam Chairman, lady. I really appreciate the chance just to speak to the board, and maybe some of my comments will be taken up a little bit later when Joe presents his proposals for the monies coming from the federal people, upcoming money. I think we all realize that the Virginia Department of Health has been underfunded and understaffed for years. And as a result, the COVID pandemic placed the health department in a tough, challenging, understaffed, underfunded position to rapidly respond, especially since previous ongoing uncertain federal regulations pertaining to testing, vaccine availability, and vaccinations was problematic. We are slated to receive about $4 billion from the American Rescue Plan, with the distribution of such resources to be determined by an upcoming special session of the General Assembly. I'm sure that the governor, the Secretary of Health, Dr. Oliver, Joe, and other Department of Health staff members have been hard at work formulating proposals considered. We know that there will be future health emergencies and pandemics. Thus, I have just one thought to keep in mind. I know that looking into the future, it's important for us in this upcoming special session on the distribution of the monies. My idea is that a significant pot of revenue should be put into escrow. And you call it a rainy day fund or whatever, but it would be a source of funding to be drawn upon solely by the health department for immediate utilization when faced with a future health emergency. I think this would be a wise decision and would be forward-thinking request. And I hope that as we move forward with Joe's presentation and with the Secretary of Health's presentation later, that the board will keep this in mind and that we individually as board members and as a board as a whole can help promote the distribution and approval of proper amendments in the upcoming special session. And I do hope that my idea or my request or my thoughts about what some of this money should be utilized for will be kept in consideration. So I thank you.
Thank you, Jim. That was wonderful. I appreciate your sharing that with all of us. And Jim has called me several times about this, and I appreciate your ongoing stewardship of this board. I believe the next person in line is Gary. Are you ready?
Yeah, just very quickly, in relationship to Jenna's questions about, or Anna's, excuse me, about the OSHA guidelines. The Department of Labor and Industry has a frequently asked questions section on their website that answers a lot of her questions. And I can actually put the link in the chat if anybody wants it. We've used it pretty heavily.
That's great. I would love that. Thank you very much. All right. I think the last person currently on deck here is Mary Margaret.
Thank you, Madam Chairman. I'm wondering what the state is thinking about doing as an employer. Is there consideration of requiring vaccinations from state employees for masking in the workplace and so on?
Thank you for that question, Mary Margaret. The state Department of Human Resource Management, DHRM, put out a guideline a couple weeks ago around this issue. And essentially what it says is that we as an employer will follow the CDC guidelines. So there's no mandated wearing of masks, or it's left up to individuals as the CDC's guidelines lay it out. So if the individual is fully vaccinated and wishes to not wear a mask, they are able to do that. If they're not fully vaccinated, they are asked to wear a mask, but it's not a mandate.
Okay. Thank you.
All right. Do we have any more questions for Dr. Oliver? Norm, have you ever felt more popular than today?
You know, actually, I wanted to thank you all for the very kind words of praise and for what VDHs and our partners have been doing over the last year in fighting the pandemic. It's an interesting situation because I'd say the overwhelming majority of cases, people are very, very appreciative, and we are feeling the love. I think Jim's point is very well taken, though, that we got to build on that and ensure that along with the love, we get the money right, to really build public health into the kind of powerhouse it needs to be. Yeah, thank you for those kind words, and we are feeling the appreciation very much.
Well, good, because you certainly are appreciated, and I don't think we say that nearly often enough. But
yeah, say it to the folks on the local level.
Yeah.
You know, it's those frontline people. You know, the EMTs, the EMS folks, the local health district employees who and others, the emergency managers and their staff. Those people are on the front line. They've been really, in a very real sense, risking their lives over this past year. You know, testing people back when there was no vaccine, and getting the disease could be a real blow to you personally and to your family. Out there vaccinating people all this time. So they're the ones who deserve all the credit.
The two people who have organized the clinic where I volunteered most frequently, I swear, I know they are over 14, but they look like they're about 14. And I'm ever so grateful for the amount of energy that they have and that they bring to this. Those of us with a few more years have a little bit less energy, but we are infinitely grateful. Okay, so are there any more questions for Dr. Oliver at all? Going, gone. Norm, thank you so much. So we are going to move on to our regulatory action update, and Alex Jansen is going to present that for us today.
Thank you, Madam Chair. One moment while we get the file up for you. All right, Madam Chair, members of the board, thank you so much. I have up on the screen the regulatory action update for today's meeting. We have 22 pending actions under development, and you can see where they fall in terms of proposed actions, final actions, and fast track actions. And there are also 2 actions that were approved that have an effective date on or after June 10th. Before I talk about those in a little bit more detail, I'm going to turn it over to Joe Hilbert to review a request to the board concerning the regulations of certifications of doulas. Mr. Hilbert?
Sure. Thanks, Alex. So, Madam
Joe,
Chair, members of the board.
can I interrupt you just for 1 second? If are we going to be voting on the certification of doulas here? Or is that going to be part of this larger vote?
I don't know that we need a vote. It's a request. You could probably do it through unanimous consent.
Absolutely. And the reason I'm asking this question is Patricia Kinzer got kicked off the internet and has been working to get back on. And I would rather not take this up when she is not here. Could
That's
we?
fine. We can come back to it.
Yeah, if you don't mind, and if she doesn't get back by the time we finish with the update, then we'll have to go ahead without her. But if there's an option to wait for, I'd prefer to.
Certainly.
Okay.
Go ahead, Alex.
Sorry.
All right, thank you. Sorry, scrolling down. So there were 2 regulatory action items that were taken by the commissioner on behalf of the board since the March meeting while the board was not in session. The first of these was for final exempt amendments to the radiation protection regulations. The purpose of this was to be compliant with federal regulations, and these were approved by the commissioner in early April. The second of these 2 actions was for fast track amendments to our food regulations. These regulations were previously approved by the board at the December 2020 meeting in order to conform to the USDA Model Food Code and would have been effective today, June 10th. Another agency, the Virginia Department of Agriculture and Consumer Services, or VDACS, was developing a parallel regulation to conform to the USDA Model Food Code, which will be effective on June 24th. To avoid stakeholder confusion, the Office of Environmental Health Services had requested that the effective date for the VDH regulations be delayed to mirror the VDAC's regulatory action, and this was approved by the Commissioner in late May. At the bottom of page 2 onto page 3 of the regulatory action memo on screen, you can see that we have 20 periodic reviews that are in process. As you know, we are required to review all of our regulations at least once every 4 years. And when we presented to you in March, there were 19. And as Joe said at the time, it was a lot. And we are continuing to work through these now even more at 20. And then on the final page, you'll see a report summarizing the executive branch review that has occurred since the last board meeting. You can see that several actions have been completed by the Department of Planning and Budget, the Secretary of Health and Human Resources, and the work that has been completed by the Governor's Office. Separately, in your binders of information, you also received a detailed spreadsheet that provides additional detail and information concerning all 22 of the pending actions. And that brings me to the end of the update. And so now is the time where, I guess, if we have any questions to allow Dr. Kinzer some additional time to rejoin the meeting, we would be happy to address them.
All right. Are there any questions from Alex before? Actually, I think we should go ahead and get a motion on the floor just for the sake of proper order, and then we can ask all of our questions. So is there a motion to approve the regulatory action update?
So moved.
Madam Chair.
All right, so we have a motion. Sorry, we have a motion for Mr. Kreitzer. Do we have a second?
Second.
Second from Ms. Hines. All right. All righty, then let's go ahead with questions. All right. Actually, Dr. Kinzer's been off for quite some time, and I'm not hearing back from her. So she just may not be able to get back. So we can go ahead and vote. And if she has questions later, we can address those individually. So Ms. Jansen, can you call the roll? Well, I'm sorry, Joe. Yes, please go back and review it.
Madam Chair, 2 things. First of all, I don't think it's absolutely necessary that you vote on to approve this report. We normally don't vote on that, but that's up to the board. Okay. But in addition, what I wanted to just bring to the board's attention, you'll recall that at prior board meetings, we presented these proposed regulations for the certification of doulas. The board directed the health department to go back and work more closely with a few stakeholder groups to make sure that there was truly consensus on the language, and you authorized the commissioner to approve those proposed regulations on behalf of the board after we met with the stakeholders. That did happen. We went back, we met with the stakeholders, there was consensus. The commissioner approved on your behalf. Those proposed regulations have been published in the Virginia Register, and they are in the middle of a 60-day public comment period. So what I wanted to bring to your attention, if you can go to the next slide, next page there, just scroll down a little bit. So the Department of Medical Assistance Services, DMAS, they are in the process of implementing a new benefit, a new Medicaid benefit for the use of doulas. And this is a big priority for Health and Human Resources within the administration. DMAS has let us know that in order for that new benefit program to be stood up, to be implemented prior to the end of this year, they need for the VDH doula regulations to be in effect. So in order to help meet that deadline, I'm requesting that the board authorize the commissioner to approve the final regulations on the board's behalf prior to the end of this year. We would obviously report back to the board concerning the status of those actions at our next meeting. And in addition, the other thing that is required in order to stand up this new doula benefit in Medicaid is for the certifying body to be designated by the board. So we would also, again, in the interest of time and helping out DMAS, ensure that this new benefit is stood up prior to the end of this year. We would also ask the board to allow the commissioner to approve the certifying body on your behalf, and then also obviously report back on that action at a future meeting. So that's the request, Madam Chair. I'm happy to try and answer any questions.
All right. Well, let me just say, first of all, that Dr. Kinzer has just texted me that there's construction in her neighborhood and their internet is totally down, but she is fine with this issue. The groups concerned have met, and she does not have any outstanding concerns. So what I think we will do, first of all, we have a motion on the floor. So I think let's get all of our questions and concerns out, and then the group can decide if they want to take a vote on the report or whether we're just fine with it as it is. So questions and concerns about the regulatory action update.
I have a question, please.
Okay. Is that Wendy? Is that you?
Yes.
Okay. Okay.
Okay, quick question, just to clarify for me, this issue of the certifying body for doulas, what does that mean? What certifying, what does that look like?
So discussed this with our staff in the Office of Family Health Services, who are lead on this, and our intention is to name the Virginia Certification Board, which is an existing entity, as the certifying body for doulas pursuant to the regulations that are making their way through the process in accord with the legislation that was passed in 2020 mandating this. So this would be the body that would actually be the certifying entity for state certified doulas, and that's what these regulations. That's a concept that's integral to these regulations. State certified doulas who would be eligible to participate in that Medicaid benefit program.
So again, I am not opposed to this at all. I just want clarification because this question came up recently where another group of semi-health professionals were certifying themselves. So obviously we need a certifying body, but I'm not clear on who is that part of VDA? Is that part of the Department of Health Professionals, the health professions? What does that body look like? I don't understand. I just want clarification.
The Virginia Certification Board is not part of the Department of Health Professions. It is a freestanding entity. It's not part of the Department of Health Professions. It's an entity that we have identified, our staff has identified as an appropriate entity to fill this role under the regulations. I can provide you with more details separately, Dr. Klein. I'm happy to do that.
Does that body certify other professional groups?
I believe so, yes.
And to whom do they answer?
I'm not entirely clear on that, Dr. Klein. I'll have to get back to you on that, on exactly what their governing structure looks like. But again, this is not something that would be, no certification body would be selected by the commissioner or by anyone until the regulations take effect, until the final regulations take effect, which we're thinking would be probably sometime in the November timeframe.
Okay. All right. Thank you.
Okay. Any other questions?
I have a question.
Okay,
Actually,
wait, hang on.
Benita. It's
Oh,
Benita.
sorry, Benita.
So 2 questions. One, have you received any comments on, online from that open comment period? And if so, what are they center on? And then I have the same question as Wendy about the certifying body. And I guess my question is, would it be more appropriate to have it be under something like Board of Medicine, or if there's a Board of Allied Health Professions, something like that, that would fall under the Department of Health Professions?
So, Dr. Miller, we have to, unfortunately, or for better or worse, the legislation that was passed last year that mandated that the board promulgate these regulations, that was all specific to the State Board of Health and not to the Department of Health Professions. So this is, the Department of Health Professions was not directed by the General Assembly through legislation to have a role in this.
So does the board that you mentioned, is that under the Department of Health? Is it in the Department of Health?
The Virginia Certification Board is not part of the Department of Health. It is a third party, okay, an external third party that we have identified as being able to fulfill this role. But again, I'm happy to provide further details to the board on that. And in response to your other question, Dr. Miller, can I see that? So the public comment period, it goes until July 23rd, so there's still a long way to go. So far, as of right now, no comments have been received.
Okay. So going, and I guess I'm showing my ignorance a little bit here. Going forward, if somebody had a concern about, their interaction with a doula going forward, would they report that to this certifying board?
I believe so, yes. I mean, but we're also responsible. We have responsibilities under the regulations, but yes, the certifying board would have a role here. And like I said, I will be happy to provide further information out to the board on this matter. And I don't know. We don't know what nature of comments we still may receive. That is an unknown. If we receive anything that's truly concerning, I will let the board know that. As soon as we know. Again, what we're trying to do here, the only thing I'm trying to accomplish is to do what we can to help the Medicaid program stand up this new benefit prior to the end of the administration, as it is a priority of theirs.
And hi, Dr. Miller. This is Linda. I'm part of that task force that's been working with DMAS and the doulas, the Department of Health, as we work to implement this. And, they are unlicensed providers, so they will have to get a recommendation from a licensed provider that is active in the care of the patient, the maternity patient, as well as they have to already have a certification training to be a doula before it goes to this doula certification body. Once they receive the certification from the state, then they will need to apply to the Department of Medical Assistance to be a provider, to be reimbursed to provide these services. In that, they will do some eligibility background checks, checking to see if they have the state certification, the training that they've received from a national certification training board, as well as the limits for any type of malpractice insurance. Once that happens, then they are then eligible to contract with the applicable managed care organizations, of which for Medicaid, we serve probably 90% of the pregnant Medicaid recipients in the state of Virginia. And once they apply to us, we will then look at that certification as well as the eligibility review that DMAS has done and provide them with a contract, and then they will be able to bill. Any time that they want to provide a service, as I said, they have to have a recommendation from a licensed provider who has been involved in that member's OB care.
Okay, thank you for that.
Mm-hmm.
Wendy?
Yes, I'm just looking at this certifying board. What Linda said, I totally support this effort. So that's not the issue at all. I would like for us to look, however, and I don't want to hold this up, but I do want to look at this certifying board. Have been Googling it. I find it very hard to get any real information about them. They describe themselves as a private nonprofit. So I just would like some clarification on what, I don't know how to assuage my concerns and not stand in the way of this, because I do support this effort entirely. So I appreciate your thoughts, Joe.
Certainly. Well, what I will do today is I will have information sent to you before the meeting's over. Okay, I'll just get in touch with our staff and have them send you descriptive information about the certification board and what they would be doing and why.
I'm just going to offer a quick fix on this, I think. We have a motion and a second on the floor, which, as I understand it, would include these regulations. Can we just pause our vote? Can we just go ahead with the rest of the business? Joe's getting that information for Wendy. We will come back to this as our last thing, because it sounds like everybody thinks this is a great idea. We're all on board, but Wendy needs that last piece of information to feel comfortable. Does that sound okay, everybody?
Yeah, I would ask Joe to do one additional step, which is simply to find out.
Somebody's got their mic on and they've got stuff in the background. If that is you, turn it off, please. Go ahead, Joe.
Would Joe please tell us what other certifications this body makes? I just like to see how far afield they travel.
Certainly.
And Faye, can I add one thing? Whether or not in the doula industry, if there's any competitors to this group, if they are considered the gold standard, or if there's someone else who might say that they certify on the same level. Because I think we all have examples of people in our industry that have differing opinions on what the credentialing is.
Okay. All right, Joe, get to work, buddy. All right, so we're going to pause, and somebody who has a better brain than me is going to remind me to come back to this when the time is right. I assume, Joe, you'll let me know when you have the information. All right, it is now time for the public comment period. Alex, did we have anyone signed up today?
No, Madam Chair, no one was signed up for a public comment.
All righty, then we can move ahead to the regulatory action item, which is the regulations of patient level data systems, and that is my lamb.
Madam Chair?
Yes.
The regulatory action item was actually struck from the agenda earlier in the meeting.
It sure was. I'm so sorry. Well, Joe, it's not like you have anything to do. Could you still talk to us about the American Rescue Plan?
Yes, could we just suspend for 2 seconds while I want to make sure we get this information en route to you from the doulas. If you could just give me 60 seconds here, okay?
All right. Well, let us take a very brief pause. Grab more coffee. Sorry, Alex, if I had been following your very good order and paying attention to what we talked about yesterday, I would have moved right on past that.
I have actually found some useful things here. And so it looks like this board is part of a larger consortium called the International Certification and Reciprocity Consortium, which does have a much more informative website and it does seem to be an appropriate organization, although the area of expertise previously has not been related to any doula-related issues. They do seem to be, it's an organization that was founded in, looks like 1981, and has been used by several states. So that makes me feel better. So I'm going to defer to Linda, who has had the most experience with this group, with this work and this project. So I'm happy to share this information. I can put this in the chat just so people know, but it does make me feel better. Again, how they would determine certification. This is, it still seems fairly nebulous, but I am reassured by the things that Linda described in terms of determining, assessing doula skills. That all has been addressed, yes?
Yes.
Okay.
And before they get to the certifying body, they also have to have the national certification. I think that's a piece that we're missing as well through the doula association. The reason that we have a state certifying body is because Virginia's regulations required a community doula. And remember, we had that conversation, it's like, well, what is a community doula versus, and so there's some just additional training that the state is looking for, and that's what that body is going to be looking for.
Okay.
Yeah.
All right. I think we can lay this to rest. I just needed some reassurance here.
Okay, Stacy, are you okay?
Yeah, I'm cool.
Okay, Jim?
Yeah, Linda is putting us at rest here, I think. Good.
Yeah, well, it's Linda, right? All righty. Well, then I think if everything's on board, then we have a motion from Gary. I'm sorry, who was our second? Who was the second on this?
Ms. Hines.
Madam
Madam Chair, I'm going to go recall Joe. He's on the phone in his office.
Recall Joe, and then as soon as you do that, we will take our vote here.
Thank you so much.
I'm sure he'll be thrilled. I like that we are thorough.
All right, Madam Chair.
All right, if you would call the roll, Alex.
Absolutely. Mr. Kreitzer?
Yes.
Thank you. Mr. Edmondson?
Yes.
Thank you. Ms. Hines?
Yes.
Thank you. Ms. Harrison?
Yes.
Thank you. Dr. Jang?
Yes.
Thank you. And I know Dr. Kinzer is having internet problems. Dr. Klein?
Yes.
Thank you. Dr. Miller?
Yes.
Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Puritz?
Yes.
Thank you. Dr. Schuler, we can unmute you if you'll give us one moment.
I think I've got it now. Yes.
Excellent. Thank you so much. Dr. Swartz?
Yes.
Thank you. Ms. Waddell?
Yes.
Thank you. Ms. Whipple?
Yes.
Thank you. Madam Chair, the vote is 13 for the motion to approve.
All right, so the regulatory action update is approved 13-4. Does anyone feel that on top of this, we need an additional vote to approve that report, or are we good with it as it is? Remember, we talked about that at the beginning of this. Wendy.
Madam Chair?
Yeah.
On your question?
Pardon me? Can I repeat my question?
Yes. Which report?
On the report on the doulas. Remember at the beginning of this conversation, Joe said we did not need to, but if we felt that we wanted to take a vote to approve the report on the doula process, we could do that. It seems like to me we covered everything in the regulatory update, but I just want to make sure everybody's happy with what we have and we don't need to take an additional vote.
I don't think we need an additional vote unless others do.
Okay. Linda, I'm going to defer to you.
Yeah.
I don't think we need an additional vote either.
Okay. All right. Well, then on we go to Joe and the American Rescue Plan.
Okay. Well, thank you, Madam Chair and members of the board. So to kind of set the stage for this a little bit, building off of the board's work this time last year actually, in which you had a lot of discussions, did a lot of work that led to submitting a set of recommendations to the governor for increased investment in Virginia's public health system. So with that as kind of the background for this, the purpose of this presentation is to provide you with an update concerning additional federal funding streams that are coming to Virginia and have already been received in order to help strengthen Virginia's public health system in various ways, and to describe some steps that the agency is taking and will be taking to ensure that those funds are put to the best possible use. And as always, your continued input and feedback to us is really important and very helpful. John Ringer helped me put this information together, and he's here with me to help respond to your questions and comments as we move through this. Next slide, please. So several different federal funding streams are now coming into Virginia as a result of the pandemic. And they are listed up here on the screen. These funding streams come to us with varying degrees of restrictions as to their use. Many of these funds are intended to be used strictly to help respond to the pandemic. On the other hand, some of these funding streams have allowed for more discretion, a little wider latitude of use, and may be better suited to help VDH and Virginia improve our public health system in ways aside from responding to COVID, and to be better prepared for the next pandemic and to do a better job in the delivery of public health services, which is all the things that have been talked about, mentioned already today. What I want you to know, one of the things I want you to know is VDH has a planning process underway to develop recommendations for addressing public health needs in Virginia over the long term, which is what we'll talk a little bit more about, but also shorter term in how to use these funds and leading up to the special session of the General Assembly, which we'll talk about a little bit here. Next slide, please. And again, as I go along, if you have any questions or comments, just please stop me, or we can wait until the end. So this slide is about the American Rescue Plan Act, which you've all heard about. We've talked about some already. The purpose of this is up on the slide so that even this one, it still has a focus on COVID-19, but it also has more latitude in it beyond simply pandemic response. The governor, the good news here, there's a lot of good news here. The governor and the legislative leadership have publicly announced several weeks ago now that funding to improve public health will be one of the prioritized uses of this funding, and which is consistent with the priorities that are actually contained in that legislation. And so this gives us a really important opportunity as an agency and as the board to provide critical input into how those funds should be used to improve public health in Virginia, what that should look like. So a little bit more background about this American Rescue Plan Act. So Virginia will receive $4.3 billion and at the state level, and then there's a separate local component to this. So cities and counties in Virginia will receive $2.7 billion directly to them. And as it's been mentioned, there's going to be a special legislative session this summer to appropriate that state level funding. We don't know yet exactly when that special session is going to be. The latest rumor that we're hearing is either the last week of July or the first week of August. That's the latest rumor that we've heard. But we are getting ready for that. So this legislation allows for funding to be used for a couple of big ways. One, to respond to the COVID-19 public health emergency, so that in that respect it continues to be focused on the response, okay? Or two, the funding can be used to address disparities in public health outcomes that have been demonstrated during the pandemic. It could also be used to respond to the exacerbation of disparities that existed prior to the pandemic, such as food, housing, or other financial insecurity. And in terms of disparities in public health outcomes, when you read through the regulations that accompany this, they're talking about funding things such as community health workers, funding public benefit navigators, using funding to provide housing services to support healthier living environments, remediation of lead hazards, and also evidence-based community violence intervention programs. But whatever lists you see in their regulations, they tell you they are non-exclusive lists. So we're hearing and believe that there is a tremendous amount of discretion that the state will have within some broad parameters of how this funding should be used. So that really gives us as an agency and you as a board a real opportunity to help fill in the blanks on what we feel is needed for the use of this money. So this funding is actually already been received. It has to be appropriated by the General Assembly, and it's essentially for 3 years. So the funding goes through December 31 of 2024. Next slide, please. So as I mentioned, there's already a planning process underway. So what we're expecting here is that the governor will send to the General Assembly a proposed plan for the expenditure of these funds that would then be subject to the legislative appropriation and whatever changes they might want to make as a legislative body. So from the administration's point of view, this planning has already started. So several weeks ago, we received an assignment from the Department of Planning and Budget to provide broad areas of proposed expenditure for these funds. The specific ask that we got from the Department of Planning and Budget was for items of one-time expenditure just for fiscal year 22, despite the fact that the rescue plan is for 3 years of funding. So we did that. Can I have the next slide, please? We provided the Department of Planning and Budget with 21 proposed areas of expenditure from the State Relief Fund. I've listed several of them on this slide, not all of them, and you can see things that we have in mind. And the first one is essentially what Dr. Schuler mentioned in his remarks, to create a special fund for public health emergency response that we can access quickly. Other things here you see, we're talking about addressing the social determinants of health, training for our public health workforce, investing in IT infrastructure, funding work at the local level to improve population health, to invest in chronic disease prevention, which is something that Jim Edmondson mentioned. We have a whole range of processes that are crying out for automation and modernization, getting us away from paper and more digital. We also included proposed expenditures around drinking water infrastructure, on-site septic systems, customer service. One thing I left out but should have put on here, mentioned by Dr. Avula, is strengthening our communications infrastructure and capabilities to be more proactive and strategic as is very much needed. So we've already sent this into DPB. We sent this in a couple weeks ago. We are anticipating that any day now, maybe even later today, for all I know, we're going to get another assignment from the Department of Planning and Budget asking us to further refine and polish up, perhaps reduce, I don't know, what we're asking for. So we have work ongoing within the agency to do that. The other thing I want the board to know is we are working as part of this whole process leading up to the special session and putting together, getting to a point where we have very concrete proposals to give to the governor. We are working with Deloitte Consulting in this regard. Deloitte has been engaged in the pandemic response, supporting the response throughout the administration with the health department for a long time now. And they are assisting us in this regard as well, and that'll be really helpful. The other thing I would mention, and this will kind of be a segue into the rest of the presentation, as we continue to refine our requests for these American Rescue Plan funds, we need to be very mindful as an agency of how we are using other federal funding streams that are also coming to Virginia. So we need to make sure that our requests are aligned and not duplicative of one another. So again, Deloitte is going to be really helpful to us in helping make that happen. Next slide, please. So the next several slides in the presentation provide a high-level overview of other new or recently received federal funding streams that we have in connection with the COVID-19 response. And again, as I mentioned, as we continue to develop and refine our spending recommendations for the rescue plan, we need to make sure that those recommendations are in proper alignment with these other available funding sources. So the first one we have up on this screen is supplemental funding from the CDC concerning the public health workforce. And so this is a workforce grant. As you can see, it's targeted at COVID-19. Okay. It's $50 million over 2 years, and there is a certain carve out that needs to go to local school divisions to support school-based health programs, and then also a carve out for local health districts. They want to make sure, rightly so, that this money gets to the local level, to the local health districts or for community-based organizations. Next slide, please.
Joe?
So we also,
Joe,
yes.
where does the other 15% go?
VDH generally?
So,
Okay.
yeah, so the
Okay.
question is, yeah, did you hear that, Dr. Miller?
Yes, yes.
Thank you. Okay. All right. We also have received a grant from the CDC to address health disparities that have become very apparent during the pandemic. We've talked about this a lot as a board, the disparity issue, and it is significant. So we have received $27 million for this grant. There is a significant carve out for rural communities of $12 million. You can see there. There are a number of strategies that are going to be supported through this grant. Will include developing new mitigation and prevention resources, improving our data collection and data reporting, expanding staff infrastructure at the local level, to have staff dedicated to this effort in each local health district, which will really be important, and also to support mobilizing our partners and collaborators to help us address both health equity and the social determinants of health as they relate to COVID-19.
Joe, does all that money have to be spent by December 31st of this year? Or is it just,
yeah,
it actually has to be spent? Oh, rats.
No, I don't think, I'm not positive that's correct. That money goes out 2 or 3 years, so I apologize.
That's correct. We have longer than just this year.
Okay.
Joe, I think Dr. Jane has a question. Anna, did you have a question?
Yeah, I do have a question, but I'm going to let Jill to finish this presentation because it's not question, it's my recommendation on how to spend funds from American Rescue
Okay.
Grants.
Great.
Thank you.
Okay. All right, the next one that I wanted to bring to the board's attention is what we call the ELC grant, which stands for Epidemiology and Laboratory Capacity. This is a long-standing grant. It's for a significant amount of money, and as you can see, it's focused on improving laboratory capacity, surveillance reporting, distribution of information, and really strengthening our ability to identify outbreaks and prepare the workforce to be able to respond to those outbreaks. Next slide, please.
Just an observation, Joe, from what I've heard, the necessity of creating, for example, lab capacity really has fallen to the states during the COVID process. The CDC either didn't do it or did it so slowly that it was irrelevant. And we got to have a means other than relying on the CDC to deal with the identification of the pathogens.
Right. Agreed, and obviously we do rely heavily on our state lab, and this grant, is much needed in that respect. You'll see that we on the last bullet on this slide that we're receiving $65 million for investment and improvement in our public health data systems from the ELC. So I think this is an example here of, there's lots of money in many different places for health IT, and it's incumbent upon us as part of our planning process to ensure that we are making the best use of all of these different funding streams, and health and IT infrastructure is just one good example of how we have to have a very careful planning process. Next slide, please. Okay, there's also vaccination and immunization money that we have received. There have been multiple awards out to 2024. We've received $207 million so far, and these vaccination awards, the way the money comes to us, it comes in cycles, and we're getting ready for cycle 4, and each cycle has a somewhat different emphasis from the federal government. In cycle 4, the funds have to support local communities. Really, the cycle 4 objective is equity and access to COVID-19, and focus on building vaccine confidence. So we are planning to use the cycle 4 funds to help improve the community outreach capacity and staffing in our local health districts. And we're going to be targeting the funds to populations that are disproportionately affected by COVID. Next slide, please. This slide, we have an application in. We haven't actually gotten the award yet, but focused on the use of community health workers for COVID response and for building up resilient communities. And you can see on the slide what the purpose is. There's a 3-year time limit on this. We partnered with the Institute for Public Health Innovation, IPHI, to apply on behalf of the Commonwealth, and they would be our agent. They would actually be the ones to receive the funds and to take the lead in deploying these community health workers in vulnerable communities across Virginia. And I know we've talked about as a board before the important role that community health workers can play and should continue to play in the future. And I think it really does get to a lot of the issues that have been raised, including comments that you've made, Jim, in the past about the importance of reaching out and working effectively with these vulnerable communities. And we know community health workers can be an important tool in doing that. And I said our application is still pending. The award can be up to $4 million a year for 3 years. Next slide, please. And then we have the coronavirus relief funds. We've actually been receiving these funds for over a year now. This was among the first first of the federal funding streams to come to the states in response to the pandemic. This money is currently scheduled to expire on December 31st of this year. And originally it was set to expire December 31st of last year, but then it was extended. There's a blank here. We have received $163 million in coronavirus relief funds. Again, this is specifically targeted at response to the pandemic as opposed to any other type of public health action. Next slide, please. So again, and I really want to focus on this. So as I mentioned, we have a number of efforts underway. We have an overall effort underway on how to plan for the use, what recommendations we're going to give to the governor on the appropriation of the American Rescue Plan Act funds. Deloitte is helping us put that together. We're expecting, I'm assuming that we're going to have to finalize our recommendations in the fairly near term. If they're talking about a special session in late July or early August, you know, it's not going to be much longer before we have to turn something in. So time is of the essence. We are also partnering with Deloitte, as I believe Dr. Oliver and Dr. Avula mentioned, to develop a vision of where we want the agency to be, what we want the agency to look like in 2025, and how to get there. And once we have that vision, you know, so we're going to make a recommendation to the governor in the next couple of weeks for the appropriation of the American Rescue Act Plan funds. But we're not finished with that. Once we have this visioning process complete, we are going to use that as the basis for developing additional budget proposals for ongoing sustainable funding in the budget submission to the 2022 regular General Assembly session. So, Madam Chair, next slide, please. That, I know I've said a lot quickly and not too much time. Happy to try and respond to any additional questions or comments or concerns.
Okay, who's got questions? I knew it was going to be you, Jim.
Yeah, I apologize for being so assertive. Anyway, I'm delighted with the planning effort and the urgency of it. On the one hand, on the other hand, I think it would be really important for a few members of this board to be interviewed or otherwise to communicate with the Deloitte people who are putting together this report. I know I've got something to say to them about possible priorities and as the policy-making body, I just think we ought to have at least some limited role of input in developing that report.
Anybody else? Anna, I know you had something.
Yeah, I have about 4 or 5 items I would like to recommend to how to include that, the American Rescue Plan. As Jim was mentioned, if, VDH allowed the board to be part of it and developing the plans, I will make that recommendation if that process is approved and started. And if not, I'm going to make my recommendation after this meeting.
Okay.
Faye?
Is that you, Jim?
Yes.
Okay, gotcha. You go.
Thank you, Faye. Joe, thank you very much for all your hard work. I know this has been a tremendous undertaking to sort through how to go forward from here with making various proposals. Of course, I'm particularly pleased to see you have as the top of the list to create a special fund for public health emergency response for the future. At some point, I think it would be helpful to the board once all these budget requests are put together, that if you would share with the board a tabulation of these requests. And secondly, if you could help instruct the board on the process of how this will go through the General Assembly for a final vote, and what we may or may not be able to do in that process to what I would call lobby for approval. So thank you.
Thank you, Jim. Anybody else?
Yes.
Hey, I had a question. I had I did that hand raising. This is Holly. I just wanted to get a better understanding, to kind of follow up on Jim's question. Who is Deloitte talking to? I think that it's great to have a consultant, but a consultant is only as good as the information they receive. And so I'm just curious as to who the makeup of that, of their information gathering sessions are going to be. I certainly agree with the board, but there may be other constituencies that may give them a more well-rounded view before they make their recommendations. Do you know how you're going to decide who Deloitte speaks to?
Dr. Puritz, I can give it an initial response, but I might want to defer to Dr. Oliver.
Yeah, I can speak to it, Joe, if you don't mind.
All right, go ahead.
So we're doing this in two phases, and the process that we're using is not one where we're just handing this over to Deloitte and asking them to come up with a report. They've had very in-depth discussions with senior leadership at VDH. They've talked to subject matter experts in our programs within our offices. They've talked to people in local health departments. I think it would be totally appropriate for us to ask our consultants to interview a few members or more of the board in the same vein of collecting some information for this first phase, which is aimed at presenting something to the secretary and the governor around our recommendations for what the administration should propose for the appropriation of the ARPA money, which is going to be decided upon in this special session of the GA. So that's the immediate thing that we're working on in phase one.
Thank you.
It's linked to and is a foundation for what we want to do in phase two. In phase two, it's a much broader sort of thing. The way we're envisioning it, as Joe talked about it, we're looking at what's the kind of health agency, what should public health look like 5 years from now? And in order to have that kind of public health agency, what do we need to do now in the way of infrastructure, workforce development? There's a whole number of areas in which we need to look at every aspect of our work and what kind of investment that would take for the state to make in order to help ensure that. We can use these monies over the next couple of years to begin that process, but it's got to be sustained. And how do you sustain that? In doing that visioning, there's the part of the visioning is going to be us as agency internally going through a visioning process around our transformation. I think of this as a transformation plan for public health. But you've heard us talk before about population health and the fact that health and equity is something that all agencies within the government have an impact on, right? Housing, transportation, social services. I mean, all of it has an impact on populations' health and well-being. As we envision the kind of public health agency we want to build, part of that visioning, I think, will mean are taking a look at how we partner with and join with all the state agencies and also all of our community partners. You know, that gap between where we are on populations, on our population's health and well-being, and where we would like them to be, that gap is one in which all kinds of folks are participating and trying to close it. Right? You got public health. You all the various state agencies, you have businesses, you have
Health plans, everything.
you know, faith-based organizations, community-based organizations, so on and so forth. So if we can figure out a way for all of those people to work together in a mutually reinforcing way, it will be far more impactful in closing that gap. So part of our visioning, I think, has to be getting the input of all of those stakeholders. So in phase two, we're going to have a much broader sweep of all the various players in population health and getting all of that input. And then I think what we would be proposing in the fall to the governor's office and secretary is not just, here's what you ought to propose to the 2022 GA for VD8, but here's a broad plan for improving public health that includes, yes, it includes things you should ask for VD8s, but it also includes things you should ask for social services. It includes things that you should ask for housing and community development. Here's some things that should be done with the transportation system. Here's some ideas that we have on energy and it's and environmental justice, and you know, on and on like that. It becomes a whole plan. So we're going to reach out to you all on the first phase. I appreciate your desires to have some input on. We do this at the special session this summer, but there's going to be even broader reach out following that special session.
Thank you so much. That really fleshed it out for me and gives me a much better sense and sounds incredibly thorough and exciting, actually. It's fun to be able to, like you said, envision what could be instead of trying to band-aid together what is. So appreciate it.
Yeah, that's all about, I think we are on the same page. Yeah, about trying to do, you know, help to build this VDH. And you say the boards will be participate in the phase one, and I will make some recommendation when they, you know, when opportunity arise to the board. Thank you.
Right. We'll have Deloitte reach out to board members as individuals.
Okay, we have
The
Wendy.
individual, I see.
Hang on, guys. I know we're all enthusiastic, but let's take turns. Wendy, you're first, and then Benita.
I do have a question for Joe or Dr. Oliver. In your first slide, Joe, is it safe to assume that the investment in public health information technology infrastructure will include state-of-the-art electronic medical records that will be uniform for all 35 health districts? Because before COVID, we all struggled with the fact that the health districts did not have electronic records and could not report data accordingly. So is that included? Please tell me yes.
Yes.
Benita.
Okay, actually, that was one of my questions. So I'm so glad to hear that, because I think without that, you're kind of dead in the water. And then I also wanted to ask if you know, all the processes like Jim referred to, well, that Danny Avula outlined with communications and how to reach people that otherwise aren't reachable or have difficulty with access, if we can build on that process and keep not just look at planning, but look at actually implementation, that would be great. That would be great. And I would love to be contacted by Deloitte if they are going to be reaching out in phase one.
Okay, is that everybody? All right, I remind you, we have one more item before Secretary Carey. So if you have feedback, I'm absolutely certain that it is appropriate to make that feedback to either Joe or Dr. Oliver. In the meantime, I'm sure that they would be happy to entertain your comments in writing as we move forward, and with some excitement finally to be heard and to feel that we're able to make a holistic difference in the future of the health of the Commonwealth. Joe, do you want to talk about the legislative updates before before Secretary Carey gets here?
I could just respond briefly to two of Dr. Schuler's questions, and they do relate to the legislature anyway. So I think his question was, what's the process going to look like for this? So obviously we don't fully know. What I can tell you is what I've heard in the way of rumors. So it's just that. So what I've heard is that the governor would be sending a budget specific to the ARPA funds. So there's a budget proposal for that to the legislature for their review and appropriation, as opposed to embedding it in the current budget and sending the current budget to them, which would then basically have the effect of opening up the current budget. So that's the one thing we've heard. So it would be very much focused strictly on the ARPA funds and not on any other funds. So that's the one thing that we've heard. And then the second thing about, Dr. Schuler's question about, well, what's the board's role in terms of supporting this, advocating for it? And I know later in the meeting, Madam Chair, you're going to be presenting a draft resolution for the board to consider. So that would be part of it. But I would just say more generally, again, we're on the priority list already, which is good. So I would say that anything that the board can do, either individually, as a board individually, or in concert with your respective constituencies, in support of what has been proposed for public health in this budget, would be very much appreciated and extremely helpful.
All righty.
So with that, I will move on to the next presentation. And what I wanted to do here, Madam Chair, members of the board, is just provide you all with a.
Yes.
Madam Chairman, this is Mary Margaret.
Yes.
Yeah, before we go on, if we would like to organize our lobbying, it's not very hard. There are 15 members of our board and not too many more members on the money committees. And if each of us took a couple of individual members, a senator and a delegate, to talk to, and we organize it so that we don't all 15 talk to one person, but we in fact divide them up, we could have a lot of effect, I think.
I completely agree, Mary Margaret.
I certainly agree with Mary Margaret. She knows what she's talking about. And those people who take the effort to speak to significant people on the money committees, they will be heard. And this is where we can jump right in and tactfully but purposefully move forward to see it properly lobbied and properly passed. So I would be open, Joe or anybody would like to, split the board up and say, well, who would you like to contact? Let's just come up with a list.
Yes, sir.
Who we're each going to do, what we're each going to do, so we know what everybody's doing. Okay.
Agree completely.
Yeah, we need to have some conversations after. And Mary Margaret, you can help us organize.
I was just going to say, I nominate Mary Margaret to help us organize who works with who. and maybe we can just informally reach out to one another. But Mary Margaret, if you have specific ideas for any of us about who we may reach out to in our area, that would be very helpful.
Sure, I'll be glad to work on that.
Okay. Should I proceed, Madam Chair?
Yes, sir.
Okay. So again, what I wanted to do here was just give the board a high-level summary of the process that we are currently using within the health department to develop draft legislative proposals for potential agency legislation leading up to the 2022 General Assembly session. Next slide, please. So, you know, we have a very, as you all know, we have a very short legislative session in Virginia, but the legislative process is continuous and never ends. So what we're doing is, you know, every year, our agency, all executive branch agencies are given the opportunity to develop and submit proposals for legislation to the Secretary, the Governor, for their consideration, and they have an internal review process, and at the end of that process, if we've done things right, certain of our proposals will be approved for introduction as legislation in the General Assembly session, and it would become an agency bill, and if the administration likes our ideas enough, they might actually become either secretary bills or governor's bills, part of the governor's legislative package, and we've had that happen plenty of times in the past. So we've been doing this for a long time, but for a number of reasons, going into this year, I decided to change the process, to strengthen it, and we're doing this. We're changing our internal processes to build a stronger foundation for developing agency legislative proposals. We have a chart up on the screen. I'm not going to go through it in detail, other than to say that we really what we're doing differently this year is we're starting our process internally earlier than we ever had. So the 2021 session was barely over when we basically kick-started our internal process for soliciting ideas and starting to develop them and vet them internally to get ready for next year. We have a group, we have a staff level group in the agency. We call it the VDH Policy Analysis Roundtable. I started this up in 2018 as a new initiative, and basically it's just about every one of our offices in the department has one or more staff who are employed as, quote, policy analysts or doing similar type work. And we all know that public health policy and development of policy is a key component of public health. So I wanted to pull together a group that kind of works in this space all the time and is thinking about this all the time. You know, we have groups for our epidemiologists, we have groups for our emergency planners, we have groups for our clinicians, but we didn't have a group for policy analysts. So I started this group 3 years ago. They've been doing different things. This year I decided that they really should be playing a role in our internal process of developing, reviewing, and vetting these proposals that come from our work units. So to date, we have gotten 20 different proposals that have come to the roundtable, and we have been meeting and working through these. We're using the roundtable to make, it's going to be their job, their role to make final recommendations to the commissioner's leadership team, which consists of Dr. Oliver, myself, and the other deputies, as well as our executive advisors. And it'll be the CLT's role and Dr. Oliver's final decision on which of these proposals actually get submitted to the Secretary's office for further review. Key process, you know, there are a number of key factors that we're looking at in terms of what makes a good proposal as opposed to a weak proposal. And among the things that we're looking at include, to what extent, for example, to what extent does this proposal help move the needle in terms of improving or addressing health equity in Virginia. And we're also looking for the level of active stakeholder engagement that we've had to date on the issues that are underlying the proposal. So again, we'll be making ultimately we'll be making recommendations. We'll be sending proposals to the secretary. He and his staff will review them. Some will be approved to go on to the governor for further review. So we would expect sometime in probably the October, November timeframe to hear from the governor on which of our legislative proposals have been approved to be introduced as legislation. Next slide, please. So I mentioned we have about 20 proposals that are still being discussed, still being thought about by this roundtable. We haven't made any recommendations yet to the commissioner. We should be making recommendations towards the end of this month. Some of the recommendations, some of the ideas that we are discussing are based on our experience during the pandemic, particularly related to health equity issues. There are also proposals dealing with a variety of environmental health issues, such as private drinking water wells, on-site septic systems. So there's always a need for clarification or modification sometimes of previously passed legislation. We have some proposals to amend the FOIA statute, which is always interesting. But the thing a couple of things I wanted to make sure the board was aware of is, as a result of this new process that we've started this year, we are seeing more intentional consideration of health equity underpinning several of these legislative proposals. We're also seeing increased collaboration between our different offices coming together to work on legislative proposals, joint proposals between offices. We also have a potential proposal where we would be collaborating with another state agency, which is also a plus, I think, anytime you go to the administration with a proposal that represents a joint undertaking with one or more agencies. I think that's always good. So that's some of our ideas. We have some of these ideas pertain to fatal, issues that we're looking at include fatal drug overdoses, equitable access to drinking water at small and disadvantaged community drinking water systems, improved monitoring of on-site sewage systems, because there is definitely a public health dimension to that, looking at the issues surrounding private drinking water wells, issues of infection prevention. One of the issues coming out of the pandemic, as you're all very much aware from prior presentations, is infection prevention in long-term care settings, an issue that we're discussing. So lots of issues being discussed. Next slide, please. And again, just next
question?
Steps here.
Yes. May I ask one question about interagency cooperation?
Yes.
Joe, has there been any continuing discussion with Virginia Housing Development Authority?
Not in terms of legislation, Jim, but we are still actively involved with them on a number of dimensions. We're in meetings with them. We are a regular participant in the housing policy discussions that are ongoing throughout the year on this. We don't have a proposal. I have not seen a proposal yet on that for legislation. I don't know. That might be something that VHDA or DHCD has in mind that they may reach out to us on.
Well, I'll send you an idea or two. I've got some.
Okay. Yes, sir.
Joe?
Yes. Yes.
Yes. Question in the environmental issues. Are you also looking at environmental health and safety inside schools?
Well, you know, we're always looking at that. I have not seen a proposal yet specifically on that point. Um, you know, so I guess what I would say just generally is we cast a wide net for ideas. And I would simply say if the board, you know, if the board members have any ideas that the board members have or additional suggestions, I know Jim's going to send us some ideas around housing. Your input on this continues to be really important and your feedback, and I want to make sure that you are given every opportunity to provide input and suggestions here. So if whatever specific ideas or even if they're general ideas that you wish to share with me, please do so. And we'll do our best to work them in. You know, if we can't get to it this session, we will definitely keep it on our list for next year. As I mentioned, this process never ends in my mind. It's always ongoing. We're always, where is the next great idea going to come from? Okay? And I want the board members to feel that they are a part of that because you are. Are there other questions on that?
Anybody?
Okay.
Okay, Jeff.
So just in terms of next steps, just up here on the screen, our staff roundtable continues to work on this. And we will be making, we're actually going to be prioritizing each of these ideas. And my plan is to present maybe the top third of these to the commissioner's leadership team in the form of a recommendation. We will share all of the proposals with the commissioner's leadership team. We will let them know how they were ranked by the staff. But I will, my intention is to present the top third or so of the rankings to the commissioner in the form of a recommendation. But obviously, it's still up to their further discussion by the CLT and final determination by the commissioner as to what the recommendations will be to the secretary. So I hope that's helpful. Appreciate everyone's comments and further offers of ideas and suggestions.
Okay, do we have anything else? All right, you got, Joe, we don't need to vote on that, do we? I'm sorry.
No, ma'am.
Okay, then you guys, we've only got just about 15 minutes before Secretary Carey gets here. And what I'm going to suggest is that we just go ahead and grab stuff, a quick coffee, whatever you need to do on your break, and that we get back here just a couple minutes before 1, before Secretary Carey gets here, and I'll convene us all then. Is that okay with everybody? Okay, see you then. Okay, folks, if everybody could start turning cameras on and coming back, I imagine the secretary will be here very shortly. Alex, are you here?
Yes, Madam Chair, I'm
Okay.
here, and Dr. Carey is on as well.
Sorry,
We saw
I could only see myself there for a second, and I just wanted to make sure I wasn't in Internet Neverland, which happens sometimes.
If you are, we're here with you.
Good, good. Well, let me call us all back together, and Secretary Carey, on behalf of our board, we are delighted to have you with us today. Cannot wait to hear from you, and it's good to see you again.
Well, likewise. Can you all hear me? I had to get in and out, and then there was so very good. Well, it's right at 1 o'clock, and I think that's when you wanted to reconvene. So if I apologize, I can't block out the sun behind me, and it's kind of looks like it's shimmering a little bit, but I hope it's not too distracting. So let's get started. Correct? Well, thank you so much. So first of all, good afternoon to everybody, and it's a pleasure to join you today. I think you're ahead of schedule, so glad that the work is going smoothly. And I just want to, at the outset, thank this group for all of your efforts to keep the work of public health moving forward over the past 15 months. And I know in your own world, it has been trying times, and we know for the most vulnerable Virginians, this has been a trying time. And again, even as the health statistics get better, we know that maybe the tsunami is down 90%. We realize there's still lots of wreckage when it comes to those most economically vulnerable, those still sorting out education and childcare issues, and folks getting back on their feet in so many ways, as well as still down to 200 more or less new infections per day, but that's still 200 Virginians and still reporting out about 10 deaths per day. So this is not completely gone. It's dramatically better, but we know the work of public health goes on, and thank you all for your service. I am deeply grateful on behalf of all Virginians for all that you've done to support being on the Board of Health, but also in your usual role. So thank you so very much. Again, your commitment to robust support for public health comes through clearly in the recommendations you developed regarding Virginia's COVID response, and I've reviewed each recommendation. Would like to share a few brief thoughts about those. So I'm happy to report that, like you, the governor and General Assembly are committed to ensuring that robust public health system. The governor and our legislative leaders issued a joint statement regarding the $4.3 billion that the Commonwealth expects to receive through the American Rescue Plan Act, outlining their intent to use a summer special session, likely in August, to allocate those federal funds to 5 specific needs. And public health is one of those 5 areas of focus, as you would expect, and as is true. Regarding stockpiling of emergency mass medical countermeasures, overall, we agree. We do need to take a look at this issue, but more importantly, how can we apply our experience to other potential emergencies where we would experience a shortage of critical supplies? Could we apply our lessons learned to other emergencies? And the Strategic National Stockpile was never designed for a national level response everywhere, more or less at the same time. Warehousing supplies for a national event includes significant challenges such as funding, storage space, stock rotation, storage requirements, climate control, and on and on. We've also learned a number of lessons regarding national and local manufacturing capacity. More research is needed to further consider just-in-time manufacturing, in which a surge capacity is built in. Despite the challenges of procuring PPE and other critical supplies, Virginia was extremely successful in developing sources of critical supplies. And one method was partnering with industry here in Virginia. A number of locations are now making N95 and other masks, gowns, and gloves, hand sanitizer, and other products, and making sure that they're able to continue to make these local supplies is important. So we look forward to investigating additional solutions, which may include some warehousing of supplies, along with building relationships with industries here in Virginia to balance access with fiscal responsibility. And importantly, the COVID-19 pandemic has escalated the importance of addressing structural and social inequities that contribute to violence. And I know that was one of those 5 important recommendations. And studies have indicated that during major natural disasters, including COVID-19 pandemic, there is increased risk of violence. And we've seen that in the statistics. We've seen that in, and additionally in overdose deaths, quite sadly, and a number of other indicators of social stress and the like. And while budget planning for the next biennium is not yet underway, we understand from the injury and violence prevention experts at VDH that with funding support, VDH could enhance its data collection systems to measure the impact of violence, train and equip gatekeepers in violence prevention, and fund and evaluate evidence-based projects to prevent violence in communities at higher risk for violence. The expected short-term measurable outcome will be the establishment of data collection systems that measure indicators of risk for historically underserved populations and communities, and increase in the number of trained gatekeepers, and an increase in the number of communities funded to address structural and societal inequities. The expected long-term measurable outcomes from this work will be a reduction in violent victimizations, as well as secondary effects such as increased gender equality, economic empowerment, life skills development, community mobilization, resiliency, and improved quality of life. We'll keep those opportunities in mind as budget planning starts in the coming months. You also asked us to consider promoting telehealth and mobile integrated healthcare through schools and school-based healthcare centers. Recent revisions to the Virginia Code's definition of telehealth originating site has laid the groundwork for expanding use of telehealth in a variety of contexts, being from the home, from school, and the like, and from acute care settings as well. Specifically, originating site means any location where the patient is located, including any public or private primary or secondary school or post-secondary institution of higher education. And prior to COVID, school-based personnel were authorized to deliver a limited set of services via telehealth, such as speech-language therapy. So that's been expanded. So going forward, DMAS anticipates expanding the scope of medical and clinical services authorized to be delivered by school-based personnel, including those delivered via telehealth. You also recommended increased provision of subsidized transportation services to medical, pharmacy, and WIC clinic appointments to address barriers to participation. So Medicaid and the Virginia Medicaid health plans provide transportation services to all Medicaid services, including medical, pharmacy, acute care, chronic care services, and long-term services and supports. As WIC is not a Medicaid service, and therefore DMAS does not cover transportation to WIC sites. However, several of Virginia Medicaid MCOs cover transportation for their members to WIC as a valued added service, and we need to continue to encourage that service provision. So I hope in the last few minutes able to kind of address those recommendations and where they stand with the administration, with the development of our budget processes. And again, we will continue to carefully analyze your recommendations on many fronts and work is underway to address those concerns that you have shared. So again, thank you all for for all of your work during the pandemic. And I also realize the opportunity that those ARPA funds and other federal funds are at this juncture to develop the infrastructure, support the local health departments better, and provide a much higher functioning public health system. Not because our people aren't great, they are tremendous, but because they just haven't had the resources, and that has been revealed by the pandemic, as we all know that to be. And the other thing I wanted to do in closing is just to recognize Commissioner Oliver, the leadership team at VDH, the team in central office, all of our 35 health districts. Just incredible courage, perseverance, and being on the front lines of testing, contact tracing, and vaccination. And by the way, all the other issues that are going on with STDs and violence and plan for well-being, trying to keep all of those balls in the air at one time. So I just could not be more grateful for the commissioner's leadership and that of his team, and just the tremendous work we've seen at the local health district level. So as we plan together what VDH 2025 or what the infrastructure needs to look like, we do have resources, and we are in the beginning phases or middle phases of planning what that will look like. So more to come, and again, thanks so much for all that our public health personnel have done across the Commonwealth. I am so impressed every day. And again, I thank you, members of the board, the Virginia Board of Health, for your leadership and for your continued support of public health in the Commonwealth. So thank you very much, and happy to hear your comments and also to address any questions that you might have.
Well, Secretary Carey, thank you for being here with us. We are, as you might imagine, a very engaged group. So we'll try to be thoughtful about time and questions. And we just want to say we like Dr. Oliver a whole lot too, and we could not be happier to work under his leadership. So, all righty. So who would like to start off with questions? And Jim, that is not a shot. So Jim Edmonds will go first. And the rest of you, if you could drop me a note in the chat, I will try to keep it in order. That I think would be the easiest way to do it. If you can't, just stick your hand up. Mr. Edmondson.
Hi. Dr. Carey, thanks. Pleasure to hear from you. We're all very encouraged that the public health is in the priorities for this windfall of federal benefits that are flowing to the Commonwealth and all the other states, and I'm sure we're going to use it wisely with you and the governor. I'm equally concerned about going forward. Public health has been generally under-resourced. My goodness, the last 15 months have taught us that. How might we and you and Governor Northam and his successor maintain the momentum of the larger commitment, financial commitment to public health when the federal money runs out? I mean, I hope that over time the availability of funding from the Commonwealth as well as the federal level will continue.
Right. So thank you very much. What I heard was really, how do we keep it on the front burner, not the back burner, and also, keep it fiscally in terms of budgetary commitment, not just in what we're talking about. And that's a great question. I mean, the funding really is a 24 to 36 month horizon. The general session coming up in August, the special session is really about funding, by what the General Assembly said in their last special session or last real session, is that they've greatly limited, unless it comes through an exact grant, anything new that has discretion over it, the General Assembly has to appropriate. So we are preparing for the General Assembly session what those priorities are, and we're in the midst of that, but it's for a relatively limited set of things, really in the end of fiscal 22, that start fiscal 22 beginning July 1 of this year until the next budget. So that is indeed what's going to happen. But I do think, and when I am on the governor's National Governors Association with supporting the governor's participation on those weekly calls, there is it really is not just in Virginia. Obviously, everyone is talking public health, and you're asking, medical practitioners, surveys, and so many of us say we wish we had gone into public health. So there's seeing the impact, seeing the incredibly important role. I think is part of that. Hopefully, our collective memory. So I think it's not sexy to put a new vaccine information system in place. It's not sexy to have a electronic health record that's functioning across the Commonwealth and all of our clinics. But that infrastructure is incredibly important. And I think what we've also seen is we've had to do through contractors, the outreach, simply to get into communities, build trust, in this case around testing originally, and then contact tracing, and now vaccination. And it's retail, house to house kind of work, and you've got to have people on the ground, not that you call in during a crisis, but they are establishing those relationships all along, and just as an example. So I think that we've got to, the Board of Health and other important governing bodies and stakeholders across the Commonwealth need to make sure that we continue to remember how important continuing that investment is. So I think that the good news is we don't have 6 months of funding. The funding really is a huge investment across years. So that's the first thing. And I think that will hopefully create what I'll call the budgetary muscle memory of how important continuing that investment is. And also making sure that it's integrated into addressing the social determinants of health and disease, as well as we look at food security, transportation security, and insecurity, as well as housing and a number of other factors that really are the drivers of public health outcomes, in addition to maternal health and the like. So what are your thoughts? I'll just maybe ask you, what are the things that you think will be key for us to do in order to be successful long term to make sure that public health it doesn't fade from memory?
I'm hoping that it becomes a standard exercise for the elected officials, as well as the senior appointed officials like you, to just keep it before the public all the time. We suffer the consequences of failing to do so, but I love your term muscle memory as it applies to this. We've got to raise the level of resources that are devoted to it, and keep it constantly before the public. I think, especially emphasizing health equity, as you clearly are doing, is a way of bringing it to the attention of the public at large through public speaking by the elected officials and the media. And I just want it to stay in as a priority.
Well, thank you. And I do think we'll find out in the election who's coming in, but I do believe that I'm a political appointee, so I'm not a neutral party here. I very much hope that a second term of Governor McAuliffe, and I have no doubt, knowing the folks around him and the folks that were with him and are in this administration, that it will indeed continue to be a very high priority. So, but you're right. It's got to be a culture. This is a cultural change that's got to occur, and I think we're seeing that. I think one of the I won't call it. There are very few positives, given we've lost almost 11,000 Virginians, and almost 700,000 Virginians have been infected. it is, I mean, over 11,000 we've lost. So, but one of the positive reactions is, I think, a much broader view of what access to health insurance is like as a public health requirement, and what civil society, how that's supported by access to services. And I really hope that is a sea change in this country that has been a difference with the U.S. compared to every other high income country in regard to universal health care and approaches. So I think public health and moving towards universal health care are the two, just the two that come to mind. Obviously, there's other social determinants of health and security that are part of true health and wellness in a civil society. So thanks for your thoughts and questions.
So I'm going to move on to Dr. Jeng, who has the next question. I will say, though, Secretary Kerry, while I totally agree with every single thing you just said, it seems to me that depoliticizing public health and making it a concern for all is going to be a key towards moving towards everything we've said about public health.
And I will just one additional comment. I will say, in my experience, these 3.5 years, I'm optimistic about that, because when I think of the leadership in the General Assembly, there's tremendous bipartisan leadership on behavioral health, on substance use disorder, on making Medicaid services most effective, and now on public health. So I do think in Virginia, for every reason, it should be it will be a public health. It will be a bipartisan priority.
Yeah, I mean, I'm a good liberal, but I want everybody to get on the boat. Dr. Jeng, could you go next, please?
Yeah, I just want to make my humble comment, and I see it's a really great opportunity for us to invest, in our public health at this moment. And my question for Dr. Kerry, that you already mentioned, we need to take a moment to think what we're going to envision the VDH will look like in 5 years. And Dr. Oliver's already mentioned, and I can concur with his comments on that, because this is going to driven us to set our priority. And not only driven what we priority, and also what we can do now is sustainable. It's not a short-term band-aid to address the issue that we already counted. What we're going to foresee what going to next 5 years and even 10 years. And I see this great opportunity for the investments. And I just want to share my humble, comments into Dr. Kerry. I'm thinking he probably already had thought of this. Mm-hmm.
Well, no, I thank you for your comments. It is, the Dr. Oliver, Commissioner Oliver, and the team are, with some vendor support, are looking first at what we need to prioritize in the very short term coming of the General Assembly session, and then how to connect that to a strategic plan going forward to truly have, it simply isn't more of what we've been doing. It's got to be transformational. And in fact, the commissioner and the team will be presenting to Dr. Vanessa Walker-Harris, the Deputy Secretary in our office that supports a public health practitioner herself, who supports VDH. They'll be presenting some, the structure or how that decision making is going to happen, and how we make sure we get broad input. And I'm sure there will be an opportunity for the Board of Health to comment on and give input about those emerging plans. But it's this governor has a lot to be really proud of in terms of all the great stuff that happened on the insurance coverage, Medicaid expansion, state-based insurance, maternal health strategic planning, and doula services, and home visiting, and a number, eliminating the quarter rule at DMAS, and a number of other great things. And I'm committed. I know Commissioner Oliver is committed to making this process that yields a true strategic plan to transform and adequately resource public health in Virginia, that is really the number one thing that I see HHR on behalf of the governor doing in our last 6 months in office. So we're really excited about that process and setting the next administration up for success as we look at our budget, as we look at how to use those federal resources to maximum effect. So thank you for your input.
Dr. Kinzer, you are next.
Oh, thank you. I just thought to follow up on Jim's comment and Faye's comment about public health maintaining attention in the public's eye and to help it be depoliticized. It's important for us to keep an eye on having a strategic plan regarding marketing. Marketing public health is going to be essential as we continue to go forward and maintain that priority. So I'm sure that everybody here knows that, but just as a reminder that I think having a strong marketing campaign, keeping that in people's awareness will be key. And I also hope that we remember how nurses play such a key role in public health. And as one of the most trusted professions, I hope that we as a state continue to pay attention to having funds continue to be used for placing more nurses, say, in school settings. I know that there is that push to slowly enhance the number of nurses in all of the public schools, which I think is really essential. So that was just my key quick comment.
Thank you, Dr. Kinzer. Ms. Whipple, you are. Oh, I'm sorry, Secretary.
Oh, no, I just was going to thank her for and just acknowledge the key. Somehow I've got some echo there, but I couldn't agree more. I'll leave it at that so we can make time for additional comments and questions. Thank you for that.
I apologize for cutting you off.
No,
Ms. Whipple, you are next. Mary Margaret. You're on mute, Mary Margaret.
There, that'll do better.
Yeah.
Secretary Carey, thank you so much for being here and for your kind remarks about the importance of public health and of our commissioner. I wonder if you could clarify for me what's going to be decided upon during the special session. So as I understand it, the 4.3 billion is to cover 3 years. And yet, as I also understand it, the requests to the various departments are to come up with proposals for fiscal year 22. So what portion of 4.3 billion is going to be decided upon during the special session? How much of that is going to be held back for future decisions?
That's a great question. And we just, again, the General Assembly, as you know much better than I do, once they're in session, they can do whatever they want. What we're hearing and what the Secretary of Finance and the governor have shared is that they do want to make it relatively narrow and how to partition which funds are go to what. But I do know our HHR agencies are the task ahead is to earmark, not earmark, but to develop what are those things that are needed in fiscal year, highest priority items to use those funds for in fiscal year 22, but also connect those to further plans down the road that are outlined, but not with the degree of clarity, because those are still strategic plans in development. We don't know exactly how we want to do it. We're in the midst of those discussions. So the short answer is that is being developed at DPB with finance and in negotiation with the money committees, exactly how they want to structure it. So it is, we're getting increasing granularity of guidance each week as they work through that work plan. So we want to be good executive branch partners to set them up for success and make sure that we've got that we use those funds as rapidly as we can for the pressing needs, and that we don't have gaps in services as we, again, address the aftermath of the pandemic and fill those gaps that were really laid very clear open because of the pandemic. So you asked the exact specificity that I just can't give you right now, but that's kind of the structure of how we're thinking about it.
All righty. Dr. Miller.
Thank you. Well, thank you. I just want to say thank you too for being with us today and giving us all this information, and what an amazing opportunity to address issues with health disparities and really achieve something, like you say, transformational. And we certainly are here to provide whatever help you need. And also would like to say, given the prevalence of dental disease, that you keep that in mind, not just for children, but also for adults. And our public health dental clinics took a big hit a number of years ago. Funding was taken away, a large part of funding was taken away, unfortunately, in a time of deep budget cuts. And so this could be an opportunity to strengthen those opportunities. But so just a thought there. And yes, I agree, it's not necessarily sexy to have state-of-the-art electronic medical records, but they are so critical. And also strengthening the partnerships we've formed, you know, in the public health crisis we've had now, we've formed some great partnerships, and so hopefully those will continue. Anyway, thank you so much.
Well, thank you for your comments, and I will, you know, oral health is health. You know, behavioral health is health, and we're really excited, as you know, that July 1, the adult dental benefit in Medicaid. I know the rates could always be better, but at least it's a huge start and very, very important, and we're really excited about that. I think we're doing a PSA next week with the president of the Virginia Dental Association. So we're really and trying to get the word out and encourage participation in that program. And there's no doubt that you know, as we really think about wellness, that oral health is so important. Nutrition, and I, as a cardiologist, I was the liaison with the dental community on anticoagulation, peri-procedurally, as well as endocarditis, and I just know how important that connection is. With inflammation and cardiovascular disease and on, how important oral health is to overall well-being from many, many different vantage points, and how important I think an adult benefit is in Medicaid in Virginia. So that starts in less than a month. So we're really excited about that. And thank you for all your leadership and the dental community's leadership on that.
Right. I don't think I have any other hands raised here, but I will just say, Secretary Carey, the bell I continue to ring is, don't forget your local government partners who are always willing and ready to help our state government partners. We have access and we have energy, and we are more than willing to help whenever we can. Is there anybody else?
And if I could comment, yeah.
Go ahead.
I may make a comment if I may. I know getting, you know, I certainly thank you for this opportunity, but that reminds me of, you know, when I finally, I was not a frontline person, so I got vaccinated at bottom of 1B, like many of us in continuity of government, but I still participated as a volunteer vaccinator and was able to get out and make visits to vaccination sites, and it was really clear that when the localities, using all of their emergency management infrastructure, all of their, you know, great folks, that they could help stand up a vaccination site, collaborated with the local health department and often with a health system or university. It was amazing. And I won't mention where, but you could see where that was a challenge early on, because, you know, everybody wants to help, but, you know, there are control issues and normal things that get in the way of that. But once they had early success, and it was really about that teamwork, we just saw tremendous added value when the localities, all of their, not just their emergency management infrastructure, but their computer systems, their communication systems, their call centers, when those things were all, it was like the old story, I forget who the author of, it's like stone soup. Everybody put in things of value to that special stone soup, and suddenly you had a wonderful, wonderful meal that was rich and nutritious. So I couldn't agree more. And that's one of my lasting lessons of, and frankly, that was one of my jobs along with the commissioners. How do we, get people together and at the local level to make sure if there were some challenges, how do we make sure that communication, that teamwork, that collaboration, and once that kicked in, it was a sight to behold just in that one area of vaccinations, and you could see it across the Commonwealth.
And Ms. Hines has her hand up.
Yes. Good afternoon, Secretary Carey. And again, thank you for being with us today and the focus that's planned for public health. I just also wanted to add, and I represent the managed care plans specifically under Medicaid. And so thanks for all the improvements that we've seen in Medicaid. But as we go forth, I would like to see us also think about adding some funding for social determinants of health. Especially the impacts that it has on this most vulnerable population. Most of us cover some aspect of it, but we have found that, the housing issue, food deserts, and we can go on and on, violence and so forth, has a huge impact on health outcomes. And what we're finding is, as we talk to a lot of people, that's, some reasons why they can't even think about getting the vaccine at this point, even though it's covered, it's free, but they have so many issues that they're grappling with before they can think about getting their vaccine.
Yeah, no, I hear you. So you're talking about, you have a lot of leeway at the MCO level to case manage and to put in what you want, but you want kind of line item support for those particular activities. And I hear you. So I think there's openness to those discussions, and I think as we go forward, we're going to realize that, if you've got adequate ventilation and you've got good filters and heating and cooling systems in place, that asthmatic person doesn't, or that child with asthma doesn't get admitted and they don't have exacerbations. And we definitely see that connection. And I know Director Kimsey is, obviously it's funding from the General Assembly, but I think there's much better appreciation of that connection and the opportunity to avoid costs. Usually you don't save enough to necessarily have a net negative decrease in cost, but that it's a wise investment, but for better health outcomes. I couldn't agree more.
Okay. I don't see any other hands. Secretary Carey, we're so grateful to have you here. We know your time is incredibly tight, and we really appreciate your input as well as your really hard work.
Well, it has been, and maybe along those lines, is I just thank you for this time with you all. And this has been, you mentioned really about, the future focus on public health. And I did not come into this. I was a clinician as a cardiologist, but I was a health system leader and definitely connected with communities. So, and focused a lot on social determinants and supporting the local FQHC and other safety net providers and working on decreased utilization and better wellness. But this was quite a education for me about public health. But I will say I was actually enrolled in a master's program at the Harvard School of Public Health, and it was the second to last weekend of that program in March of the first weekend in March of 2020. So that was the day, March 7th, that the first case of COVID was diagnosed here in the Commonwealth. And I felt so fortunate that I was able to work with the governor and the chief of staff to allow me a little bit of time to advance my studies in management and public health. And it really came in handy in many parts of this role for the first 2 years so that I could really be ready for the third year to lead more effectively. So it has been quite an education to build on that theoretical knowledge of how to really address, again, a hopefully once in a lifetime type of public health emergency. So this has been a journey that we've all been on, but has been a particularly meaningful to me to put some of those lessons learned to use, essentially right away. So thanks so much for this opportunity. I know you have other business to conduct, or at least to close your deliberations for the day. Thanks so very much for this great opportunity to hear from you and also to be heard. So thank you.
Thank you very much.
Bye-bye now.
Bye-bye. All right, folks. I hope I got everyone.
I did have my, I guess you didn't see it. Okay.
I didn't see you, Catherine. I am so sorry. But if you'll let us know your question, we will forward it on to the secretary. I'm sure you have as much access as any of us do.
Really wanted to thank him for coming. The secretary and I had lots of conversations earlier, not through, but relating to the distribution of the vaccine, and he was very good at time. So I just wanted to thank him. That's all. I don't have any questions.
Okay. Thank you. All right. Well, folks, the next item on our agenda today is other business. And before we get on to elections, I just want to say, in light of our presentations today and the upcoming special session, I'd like to present a resolution requesting increased funding for Virginia's public health system. Alex, could you please put that up on the screen? I'm going to read it and see if we are in agreement about this.
It should be on the screen, Madam Chair. Can you see it?
Okay, I can. Thank you. I'm going to read off of my copy, so please let me know if I make any mistakes. I don't think so. And I just want to say a number of folks are to be thanked for the input on this document. It is certainly not mine. Whereas the COVID-19 pandemic has highlighted a wide range of public health issues, as well as the importance of Virginia's public health system, and whereas the State Board of Health provided a series of recommendations to the governor in September of 2020 designed to strengthen Virginia's public health system and address socioeconomic disparities in health opportunity, and whereas the Trust for America's Health, in a 2021 report titled "The Impact of Chronic Underfunding on America's Public Health System, Trends, Risks, and Recommendations," stated that underfunding continues to jeopardize health, safety, and well-being of residents. And whereas the Association of State and Territorial Health Officials has stated that sustainable longitudinal investment in public health infrastructure is necessary to, 1, ensure foundational public health services for all communities, 2, build a 21st century public health workforce, and 3, modernize public health data systems. And whereas the American Rescue Plan's Coronavirus State Fiscal Recovery Fund contains an estimated $4.3 billion for Virginia, and whereas the governor and leaders of the General Assembly have recognized that public health services have long been underfunded and have prioritized the needed use, sorry, we've got a typo here, and have prioritized the need, use a portion of the $4.3 billion to upgrade, I'm going to try this one more time, sorry, and have prioritized the need to use a portion of the $4.3 billion to upgrade state and local public health services. And whereas the Virginia General Assembly will be convening in special session for purpose of appropriating funds from the Coronavirus State Fiscal Recovery Fund. And whereas the Virginia Department of Health has been planning for what Virginia's public health system should look like in 2025, and will present the governor with recommendations for new investment in Virginia's public health system in support of that plan. Now, therefore, be it resolved by the State Board of Health that the Governor and General Assembly take all necessary actions in preparing for and during the upcoming special session to prioritize the appropriation of additional funding for Virginia's public health system, and be it resolved further that the State Health Commissioner transmit copies of this resolution to the stakeholders of Virginia's public health system so they may be apprised of the sense of the State Board of Health as to this matter. All right. Alex, if we could fix that one little typo, the need for the word to, I'll point it out to you. Questions or concerns or comments about the resolution? Would we all be happy to send this on?
Question.
Absolutely. I think it's great.
Okay, so I don't know who the first was. Holly, was that you?
Yes, sorry.
Oh, all right. Did you have? Go ahead. I've got a tiny bit of a time lag here, so I am sorry if I am speaking over people. Holly, did you have a comment?
My comment was just in support of it. I think it summarized very nicely really the gist of the meeting and Jim's earlier remarks, Jim Schuler's earlier remarks also. So I feel like it's a very good summary of what we've been saying at these last meetings.
Right. Jim Edmondson?
Just, I also think it's excellent. One possible addition, given what the secretary said, is that there's a recognition that sustainable funding from the Commonwealth needs to be created beyond the 4.3 billion windfall that's coming in, and we might make reference to the desire for sustainable funding from the Commonwealth to be built into the expectation.
Okay. Sustainable ongoing funding, I think, would be the.
Yes.
Yeah. Okay. Anybody else?
Faye?
Yes. Jim Schuler, is that you?
Yes, thank you. Would it be possible to be a little more explicit on the special fund idea that's part of the governor's, joint press release a few weeks ago with the leaders of the General Assembly? Could we be a little more specific on really striving to at least attempt to get a special fund that could be drawn upon by the Department of Health solely as needed, when needed, without having to wait for further appropriations? I'm talking about that rainy day fund. Okay.
A rainy day fund for public health.
Right. I mean, you cannot tie a General Assembly, a future General Assembly, to a budget. That's something that's debated every year. And if it's 2 years from now, another public health issue, major emergency, I'm looking for a way to the health department to be able to have a pot, a resource, money to immediately go to immediately get into action without having to wait on, legislators making up their mind.
Joe, can you speak to that? Joe?
Yes, I heard that, Madam Chair. Delegate Schuler, thank you. Certainly, we can make further revisions to this. That's not a problem at all. I think with respect to Jim Edmondson's comment about, looking beyond just the 4.3 billion and looking towards, beyond the special session for a call for more sustainable long-term funding. I can easily that can easily be built into this as an additional whereas clause. And with respect to Dr. Schuler's comment about the special fund, I'm looking, certainly we can figure out a way to put that in here as well. The way it's drafted right now, I didn't make any effort in here to really drill down into the specific areas of expenditure. I kind of left it under, improving Virginia's public health system. But we can certainly figure out a way to, if that's the will of the board, we can certainly figure out a way to incorporate in the reference to a special fund as well. Happy to do
I
that.
feel pretty strongly about that too. I think that's a great idea because you don't always have time to wait.
I second or third that.
They also,
Yes,
I've been trying.
I
Totally
think you've got
agree.
consensus.
Well, I want to ask a question first.
Can we take down the, okay, go ahead. Mary Margaret, is that you with the question?
So I'll wait till Catherine, I'm sorry.
I'm going to agree with Jim Schuler and that I think the rainy day fund idea is just perfect for the health department because you never know when you need it then.
Okay, Mary Margaret.
The question I have is that the General Assembly has established a cash reserve separate from the rainy day fund. And is there anything that prevents a public health emergency from drawing on that cash reserve?
I don't think there is, but there's also nothing that obligates it in any, like, I don't think we could say we've got dibs. That is my take on it, but Joe, what do you think?
I think
I was going to say, to Ms. Whipple's question, I don't think that the health department does not have any authority to draw on that money in the event of a public health emergency. Like the General Assembly would have to appropriate it to us to give us permission to do so. So they could insert language into there, but I think they would put parameters around that in the same way they would any other special fund to draw access to.
I think what I've understood, taken away from my discussions with Dr. Schuler about this and listening to the board more, and just knowing what our circumstances are as an agency, what's really missing is flexibility and ease of access to significant amounts of money on very short notice in order to ramp up quickly. That's what I believe the intent of the idea of a special fund, whether you call it a rainy day fund or whatever label we want to use, but the real need is for rapid access, flexibility, and sufficient size of the fund so that you can quickly have we can quickly have access to a source of funding that we largely, quote unquote, control, although there's always going to be parameters around that, right?
Right.
But right now, what's happened, what typically happens is we kind of, something bad happens, we have to respond, and there's always this waiting game, even if it's just a week or two, right? And where we have to kind of wait for the money to start flowing from somewhere. And that's what's really needed is a way, is some new vehicle that we would have much more rapid access to decrease the waiting game and to allow us to ramp up quickly and start doing what needs to be done.
Okay, thank you.
Madam Chair.
Yes, sir.
Joe has laid it out perfectly clear. And I think if we stop and think a little bit, back in December and January and February, the health department was inundated with massive calls. And what are we doing? And what's going on? and we were still working under an unpredictable national policy at the time. So it left the health department in one hell of a position. And I think at the time there were only five people there that could handle all the work that was being put down on them because of I don't want to be careful what I say. I want to be careful what I say about the national scene, but it left the health department in one hell of a mess. And you must agree with me that it was a wonderful job that all the staff did with the resources and staffing that they had. But we don't have to be faced with that again in the future if we had a dedicated source of funding that we could draw upon immediately in a future health emergency or pandemic, whatever you want to call it. Okay?
So I would venture to say that there is consensus that there needs to be this special fund, and that in putting a clause in this document is a good idea to emphasize that. Is that correct?
I think you got it, Wendy.
And I think, as Mary Margaret sagely suggested, as we move forward and we lobby, we work to speak to our elected officials we can certainly, promote this because it is clearly critical.
So as I see it, folks, the two additions to this as it stands are something that talks about ongoing sustainable funding and a rainy day fund. Are we all agreed about? I think we just need consensus on that before we vote on this. Okay.
Now, you already have in the document, there is the word sustainable. So I'm not sure we need to repeat that. At the very beginning, it says, whereas the Association of State and Territorial Health Officials has stated that sustainable longitudinal investment. So
yeah, that kind of does mean just ongoing, doesn't it?
So, I mean, we can certainly add it. I'd rather not make this longer than it needs to be. Right. But I do think a clause that promotes the importance of the rainy day fund is worthwhile. That's my suggestion.
Okay, so Jim, would you hang on one second? Hang on one second, Catherine. Jim, would you agree that sustainable and longitudinal is the same as ongoing? And that...
No.
Okay.
No, I think it's sort of buried there. I think we need I would like to see a specific whereas clause.
Okay, well, I don't think anybody's going to fight you on it. I just want to make sure. Okay, Catherine.
Do we have to decide this right now?
Well, I think the sooner the better. Is there a reason not to decide it now?
Well, because we all seem to want to add a clause in there that makes sure that it's saying exactly what we want.
I think we only have these two major issues. Perhaps, I'm sorry, I'm getting terrible feedback, so stop me if I'm talking over you. I think what we could do is make sure that we get those two things in here, and then certainly we can send this around for everybody online before we get a final approval on it. Joe, we can do that, can't we? Joe.
I'm sorry.
My bad.
Yes, sorry. Yeah. Yes, we can. We will develop a revised draft that adds 2 additional whereas clauses along the lines of what's been discussed. I will send it out to the board email distribution list, and I would just ask people just to respond to me individually and not reply all like we usually do.
Yeah, remember, reply all constitutes an illegal meeting.
Because we're trying to get this so we can get it to the General Assembly before the special session, correct?
Yes.
So yes.
Yes.
So I think time is of the essence.
Yes, agreed. So. All righty. Is there anything else about the resolution?
Yes, Madam Chairman, this is Mary Margaret. I would strongly urge we don't fill up this resolution with a lot of individual items.
Yeah, I think right now that unless there's some overriding concerns What we are really commenting on via email is the addition of those two items, right? Those two issues that I don't think we need to put more. And I believe I see consensus among the group that we should stick with what we have with the addition of those two things, but we just like to see them before they go out. Is that, could you all nod your heads yes if that makes you happy? Okay, all right, good. Alex, that was a nonverbal cue that we have consensus. All right, guys. Anything else on that issue? All right, well, the only other business I believe we have at this point is the report of the nominating committee and a vote on officers for next year. And the chair of the nominating committee is Stacy Schwartz, right in the center of my screen.
I gotta unmute me. Okay. So thank you, Madam Chair. The nominating committee met this morning at 8:30. And thank you to my partners in crime, Dr. Kinzer and Dr. Miller. We would like to bring to the board the following persons for consideration for officers for next year: Faye Pritchard for chair, Wendy Klein for vice chair, and Jim Edmondson and Jim Schuler as executive committee members.
Joe, I cannot remember how this goes. Clearly, I do not conduct the vote. Does Stacy conduct the vote of the board?
So Madam Chair, you should have, we need a motion and a second to adopt the recommended slate of officers.
Do we ask first if there are any outside nominations? Anybody else? All right, then we do need a motion and a second to adopt that slate of officers.
This is Dr. Pierce. I move to accept the slate.
That didn't go well. Holly first and then Mary Margaret.
I move to accept the slate that Dr. Schwartz just presented.
Mary Margaret, was that you too?
But the point I was going to make is that you do not need a second when the recommendation comes from the nominating committee.
Okay, thank you. All right, so we have a motion. Are there motions from the floor? All right, then Alex, could you call the roll?
Yes, Madam Chair. Mr. Kreitzer?
Yes.
Thank you. Mr. Edmondson?
Yes.
Thank you. Ms. Hines?
Yes.
Thank you. Ms. Harrison?
Yes.
Thank you. Dr. Jang?
Yes.
Thank you. Dr. Kinzer?
Yes.
Thank you. Dr. Klein?
Yes.
Thank you. Dr. Miller?
Yes.
Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Puritz?
I'm sorry, I thought I was on unmute. Yes.
Thank you. Dr. Schuler?
Yes.
Thank you. Dr. Schwartz?
Yes.
Thank you. Ms. Waddell?
Yes.
Thank you. Ms. Whipple? Oh, she's unmuted now. Oh. Ms. Whipple?
Yes.
Thank you. Madam Chair, the vote is 14 for the recommendation.
All righty. First, let me say, thank you. As most of you know, this is my last year on the board. I'm about to time out. And so I am very grateful that you're at your confidence that I can make it through this final year. I want to thank Linda Hines for being a wonderful vice chair for the last few years. And I'm sure Wendy Klein will turn to you for support and questions and all of that. And Jim, I don't know how I'll keep you straight, but thank you for agreeing to serve on the executive committee. It's got to be easier than last year, right? Is there anything else today, or do we have member reports today? Is there anyone who has a member report today?
I'd like to make one comment, not so much a report. Michael Lewis, the great bestseller author, has just issued a new book called Premonition. It's about kind of a history of public health leading up to the COVID crisis. And it reads more like a mystery novel than a nonfiction book. It's truly remarkable. I found it so. The biggest takeaways are that local and state health officials are grossly underappreciated. And he makes heroes of a number of people who were deeply involved in public health historically, but in particular leading up to and during the COVID crisis. One other key takeaway is that to a large extent, state and local health agencies are on their own. The CDC was described by one of the participants as a peacetime institution in a wartime environment, just not capable of acting fast enough. All the more reason for Jim Schuler's recommendation of an emergency fund to be put into place. Anyway, strongly endorse it. It'll be worth your time to read it.
What's the title again, Jim?
Premonition. It's Michael Lewis. It's on the New York Times and every other bestseller list right now.
Okay. Thank you. All right. Are there any other member reports or comments? Wendy?
I have a question, which I'm kind of curious to know whether there has been any discussion or what other people feel about meeting in person in future or having a hybrid meeting, because I know that it is in some ways tremendously advantageous for people not to have to travel. On the other hand, I miss you all. So I don't know what others think.
Wendy, we're working toward an in-person in September, if that's possible. We certainly want to be respectful to what members feel that they can do. I will say this, as someone who has been teaching college freshmen for a year during this pandemic, the hybrid model where there's an in-person meeting and some people are phoning in is a very, very difficult model. So for me, I think unless there's some outstanding issue for a member, we should try to do all of one or the other.
Faye?
Yeah. Yes, sir.
I would imagine that all the board members have been vaccinated twice.
Well, not those of us who got Johnson & Johnson.
Well, but you know what I mean. Let's put
Yeah.
it this way, fully vaccinated.
Yeah.
And I would imagine that staff is fully vaccinated. And if there's some other concerns that could be taken care of, but I certainly would hope that we could get back to meeting in person. It's tough, you know, you can't look around the room and see what's going on or generate any response to anything by doing it by Zoom. And you've done a great job. I'm not complaining about anything, but I just think that we'd have a more effective, satisfying board meeting if indeed the parameters can be worked out to where we can meet in person. And hopefully that'll be in September. Okay.
So what I hear you saying is you miss us too?
Well, yeah, you know, I live way down here in far Southwest Virginia, don't have many friends.
I bet that's not true, but we miss you too.
It's nice to go to the big city once every 3 months.
Do we have anything else from anybody else? Then I adjourn this meeting and I look forward to seeing your real faces in September.
Thank you.
Thank you.
Bye-bye, everybody.
Be
Bye-bye.
safe.
Yes.